Beautiful. So yeah, welcome. Thank you for coming. I'd just like to kick off today by acknowledging that I am currently on the land of the Kaurna people and pay my respects to Kaurna elders past and present. And I'd also like to extend that to the traditional owners of wherever you may be. Not everyone's on Kaurna land today. We've got a few people coming in from interstate and some people from up north and over on the west coast. So I pay my respects to the traditional owners of the lands wherever you are, and to elders past, present and emerging, and also to any Aboriginal and Torres Strait Islander people we have attending with us today. You might even like to, in the chat, if you would like to mention what country you are on today, whose country you're on today, then we can see where we're all coming from today. Not much housekeeping on an online event. You all know where your toilets are and your emergency exits and all of that stuff. I'll just ask the panelists to keep your camera and microphone muted whilst you're not presenting. And I'll sort of invite you to unmute yourself when it's your turn to present. Questions in the Q&A function, as I mentioned. Just to quickly mention too that there will be an email coming out sometime during the event, which will have an evaluation survey. So that'll be there ready for you in your inbox when we finish today. We'd really love your feedback about today's event. Unfortunately, it's not the event we planned, which would have been great to have everyone in the same room. But it is what it is, and we do what we can in these times, I suppose. I think that's it from me. So I might just hand straight over to our Executive Officer, Michael White, who's just going to give you a bit of an update on what SANDAS has been up to.
Hi and good morning. Welcome everyone. Like Sam, I'd like to acknowledge that I'm on the land of the Kaurna people and pay my respects to traditional owners of the Adelaide Plains. Probably the most obvious thing that SANDAS is facing, as are you all, is COVID-19, because that's why we're all at home in our jammies instead of being at the pavilion having coffee and cake. I suppose the most important thing is to clarify is that AOD workers are defined by the Department of Health as essential workers. And so you're authorised, allowed to continue to work as you would normally. Some of you may opt for telehealth or phone consultations, etc. That's up to you. But it's important to know that if a client comes to your office for treatment, etc., that's a permissible journey, irrespective of where they live or how far they're travelling.
Michael, I've just been alerted that your camera's not working and people can't see you.
Oh, I can see me.
Ah, okay.
Can people hear me?
We can definitely hear you. Yeah, we just can't see you. Maybe we just continue.
I think there's possibly a lag on my internet, because it's very slow to turn things off and people's messages are coming up quite slow.
Okay.
So we might run without me on camera.
Okay.
But,
all right, no worries.
So you'll just have to live with that. I have tried turning the camera off and on, and it's so slow that it's not doing that. And it looks like when I turn my camera off, it turns off both of our cameras, Sam. So just a few other things, given that you can hear me. Sam's been working on an AOD treatment fact sheet, which is a brief guide to what treatment is and how it works. which will be published soon. A lot of you have provided input into that, and that includes the community consultation group with DASA. So we're very grateful for the input, and you should see that coming out as a published document soon. SANDAS is also undertaking a networking needs analysis, and that's a questionnaire that's asking how you would best like to be engaged in networking across the sector. And that's looking at whether that's a series of networking meetings or networking events. It's open for you to suggest what would work best for you. The link will be sent again with the evaluation service, and it would be really great if anybody who hasn't completed does so. The more people we get, the better idea we have. SANDAS has just launched a jobs board on our website. We know that at the moment there's quite a lot of flux in the sector, and organisations are looking for people, and people are looking for organisations. So if you've got a job that you want to advertise, send a brief description of the job to Sam. You can cut, copy and paste what you've used on Seek or any other job board, and we'll pop it up on our jobs board. It just needs a hyperlink back to your application process. As you would know, we were about to run further training with 360 Edge on trauma-informed care. Unfortunately, Paula, who runs those workshops, comes from Victoria, and there are restrictions in getting her in and out, and so they need to be rescheduled. What we're going to do is wait a couple of weeks at this point and see what happens. We've got up till next June to deliver, and we would prefer to run those face-to-face. They can be run online, but at the minute our preference is to run them face-to-face. And so they will be rescheduled when the borders open. It shouldn't be long. Thanks for the responses to the National Minimum Dataset training scoping. This was training that we ran 18 months or 2 years ago. It just gives people an orientation to the National Minimum Dataset. The intention of the training is to ensure that across the sector, people have the same interpretation of each of the fields within the National Minimum Dataset, and that makes for the most consistent state data. We've had a high level of interest received, and we'll look to run the training before the end of the year. Again, it's training that we would prefer to run face-to-face, but it may very well end up being online. Next is that in September, we normally run a symposium, a full day symposium with a range of speakers from around the state and interstate, speaking on topics of interest to the sector. This year, because last year's symposium actually occurred early this year, rather than doing another symposium, we're going to do a seminar series, which will be a lunchtime seminar series. And at the minute, we're planning for 4 seminars. And we're just working on the speakers who will speak at those seminars, but we're hoping to get Stephen Bright from WA to talk on psilocybin and other emerging treatment opportunities arising out of some of the, I've lost the word, but I'm going to say, psychedelic drugs. Psychedelic was the word. It's a word that you lose if you think about it. On psychedelics, we're going to have a workshop from Caitlin Hughes at Flinders on the challenges and opportunities of drug. We've got a few other people that we're approaching and lining up. So watch the space. They'll be generally 1 hour sessions. So there's something that if you're sitting at your desk having your lunch, hopefully it's something that you'll enjoy watching. There's one other major project that I'll highlight, and that is that currently there's a review of the Liquor Licensing Act, and we've been working with a number of national and state-based organisations, the Australian Drug Foundation, the Foundation for Alcohol Research and Education, the Public Health Association of Australia, on providing feedback to the government on how to address changes in the liquor licensing laws. Of major concern is the extension of the home delivery of alcohol, basically to any licensed premises, and the facilitation of rapid delivery of alcohol, which we know from research in New South Wales can lead to people who would otherwise have stopped drinking, continuing drinking, and is associated with family violence and a range of other concerning behaviours. So we're hoping that that review will listen to the input from that broad range of organisations and choose to restrict licenses rather than free them up. For anybody who's interested and can see my background, I don't know if you can, my background is Ikara, or the Flinders Ranges National Park. And if I wasn't at home talking to you guys, that's where I'd really love to be. Okay, I'll hand back to Sam, and we'll start with the presentations. Thank you.
Thanks, Michael. I just forgot to mention in the housekeeping that we will be having a morning tea break, so we're not going to power all the way through to lunchtime. We'll take a break around about 10:30 to give people a chance to go to the toilet and grab a coffee and their morning tea and whatever. So we will be doing that. But next I'll hand over to Alan Trifanoff from Adelaide PHN to let us know what's going on there.
Thanks, Sam. I will just share the screen. There's been a late change to who's presenting this morning. Unfortunately, we were going to do a double act, Fiona and I, but Fiona's unavailable, so you're just going to have to put up with me for the next 15 or 20 minutes. So apologies for that, or, you know, right. Sorry. Now, before we start, I just want to acknowledge the Kaurna people, who are the traditional custodians of the Adelaide region, and we pay tribute to their physical and spiritual connection to land, waters and community, enduring now as it has been throughout time. We pay respect to them, their culture, and to elders past and present. And taking up Sam's point too, I'd just like to acknowledge the custodians of the lands in other parts of South Australia and wherever else you may be in Australia. I wanted to just give you a quick overview of what I'm going to cover today. So we'll be starting with the commissioning cycle that the Adelaide PHN adopts, the needs assessment, our AOD treatment and quality framework, which was developed last year, a brief overview of consultation that we undertake, a brief overview of also the procurement, contracts and compliance processes that we have, and that includes our new commissioned service providers who commenced on the 1st of July, and most of whom will be presenting throughout the morning as well. Also wanted to highlight the focus on outcomes and outcome measures, and a brief overview of data collection. I won't spend too much time on this because I think most people would be aware of it, but I just wanted to quickly give an overview of the commissioning cycle that the Adelaide PHN undertakes. The key to it is the central point there, the community and stakeholders. And the commissioning cycle is informed by needs assessment research, followed by design, procurement, contracts and compliance, and monitoring evaluation. With the needs assessment, that's probably the crucial thing, along with the community engagement and stakeholder consultation. Adelaide PHN undertakes an annual needs assessment, and we have a needs assessment framework that informs that process. And in doing that needs assessment, what the PHN does is it collects information, analyses health and service needs of the Adelaide PHN region, including emerging substances of concern, and also ensuring an understanding of what access stakeholders, consumers, and services have to services. It includes consultations with membership groups and key stakeholders to inform both priority setting and identifying new and emerging needs. The PHN has a number of membership groups that it calls upon, including a Community Advisory Council, Aboriginal Advisory Council, a network leadership group, just to name a few. What the needs assessment then does is it's used to inform the prioritisation and targeted activities that are needed to address identified needs. And in 2020, Adelaide PHN also worked with DASA and Country SAPHN to contribute to a statewide AOD needs assessment. And the findings of that will be used by us to inform our needs assessment that we are required to develop in November 21. So looking at the current needs assessment, the AOD priorities for 21-22 are priority populations and ensuring that they have access to high quality AOD treatment services and interventions, ensuring that primary healthcare providers identify and support people with substance use issues, and also understand the scope of the treatment services and primary healthcare services that are available. We also ensure that people who need AOD treatment services in Adelaide are supported by a sufficient, safe, skilled and appropriate workforce. There needs to be an integration and partnership between AOD and primary healthcare services to ensure continuity of care and experiences and a quality improvement process that goes with that. And there's a need to increase access to and availability of culturally appropriate services, including and particularly AOD services for Aboriginal and Torres Strait Islander people. In 2020, Adelaide PHN went through a design process which included developing a treatment and quality framework. And what that framework does is it translates the needs assessment into an outcomes-based service model and identifies the projects that need to be commissioned. It draws upon a collaborative process, including expertise, experience, capabilities, knowledge, and the data of key stakeholders. It aims to avoid duplication, and we're looking to commission a complementary mix of services that align with what DAS is doing, but doesn't duplicate what they're doing. And it also aligns with the Adelaide PHN and Commonwealth strategic and performance frameworks. What I did before today was I provided Sam a PDF copy of that treatment and quality framework. And I guess if people are interested in getting a copy of that, if they let Sam know at the end of the session, she can forward that on to you. The commission service providers that we recently commissioned would all have copies of that as part of the information package that I've provided prior to the 1st of July. So if we look at design more broadly and look at what the principles that underpin design are, what we're trying to do there is to ensure that there's a consistent high quality service delivery across the region, which is underpinned by treatment principles, quality principles and governance principles. And from a treatment perspective, given that this is an AOD treatment services forum, there's a focus on person-centered, equitable and accessible, evidence-informed, culturally responsive, holistic and coordinated, non-judgmental, non-stigmatizing and non-discriminatory treatment service. And we aim to ensure that all of our service providers adhere to those, as well as ensuring that we do ourselves as well. So in developing the AOD treatment quality framework and through the consultations that were undertaken, a number of priority groups and populations were identified. So they include Aboriginal and Torres Strait Islander people, children and young people, culturally and linguistically diverse communities, the lesbian, gay, bisexual, transgender, intersex and queer questioning communities, or LGBTIQ, older people, people in contact with the criminal justice system. And while methamphetamine is not necessarily a priority group and population, it is a priority substance that's been identified by both the state and Commonwealth governments as an area that needs to be addressed. So as part of the design process, there's a focus on interventions as well. So ensuring that the framework identifies the interventions that are both in scope and out of scope, and that what's expected of each of those interventions. And it draws upon a whole raft of references and resources that are already existing out there. So it's not anything that we've created that's new, but it's all based around evidence-based and informed interventions. And so the things that we are funding and focusing on are peer support, family support, drop-in services, information and education. So that's from a harm reduction point of view. From a screening, assessment and coordination point of view, there's focus on screening, brief interventions, assessment, care and recovery coordination and case management, consultation, liaison for inpatients admitted to hospital. And while I'm talking about screening and assessment, I just wanted to highlight a new resource that's been developed by the National Centre for Education and Training on Addiction. And those of you that know me know that I, until this year, spent 13 years working there. So I still have a bit of an association with them. But they produced an online portal of screening and withdrawal tools that are commonly used within the AOD sector. And all of those tools are available online. They include the actual tools themselves, links to descriptions of the tools, and where to get further information. So for those of you that haven't already seen it, I would recommend that you have a look at it, because it is a really useful resource in your day-to-day work. The other intervention group that we focus on are intensive interventions, so things like counselling, withdrawal management, non-residential rehab, and limited pharmacotherapy. And with non-residential rehab, I just need to qualify that what we are not funding through our services is residential rehab, because that's an area that we saw would be duplicating and cutting across what DASA and other services are already providing. So in the design process, as I've mentioned in passing, there was a very strong emphasis on consultation, and the consultation that was undertaken included broad-based AOD sector consultation, Aboriginal and Torres Strait Islander consultation, and lived experience. And that took the form of interviews, online fora, and surveys. And we wanted to make sure that the stakeholders that we consulted with were given an opportunity to comment on the draft framework, and that they were satisfied that it supported efficient, effective AOD treatment services directed at the greatest need. And the consultation also informed specific treatment design for Aboriginal communities. And one of the things that we identified through that consultation, particularly through our Aboriginal Community Consultation Council, was the need to ensure that Aboriginal and Torres Strait Islander people were provided with a variety of options, and that they had choice, and that they didn't need to just go to community controlled organisations, but there was a need to ensure that mainstream services were able to provide culturally appropriate, culturally safe services for them as well. And the key themes that came out of the consultation were the support for the development of the peer workforce and a greater recognition of the peer workforce. And those of you that have been around for a while would know that the peer workforce, the focus on the peer workforce, is something that's been gaining a lot of traction over the last probably 4 or 5 years. Other themes include care coordination and practical based support, harm reduction over the life course, particularly for cannabis use. Aftercare is a key for relapse prevention, and the whole focus on relapse and relapse prevention, and identifying the need to support people both when they're lapsing and relapsing. And I know that the harm minimisation team at Nunkarawarra Unity last year produced a really useful hard copy resource around relapse prevention, which was targeted at Aboriginal and Torres Strait Islander people. It's visually and informatively really a really good resource. So I would really commend that. And, you know, if you need to access copies of it, certainly contact Nunkarawarra Unity, because I think it's a really valuable resource. There's a need for cultural awareness and safety strategies, and that's essential. Ensuring that integration opportunities are further developed, and a focus on consistency in performance and outcome measurement to ensure that we get improved data, and that's data across the board for both reporting purposes, but also client management systems as well. So as I mentioned at the outset, come the 1st of July, we had a raft of commission service providers commence, and I'll just give you a brief overview of who they are, because I know that most of them will be doing a quick fire presentation later on this morning. So we have Mission Australia providing two major programs. One's the Drug and Alcohol Youth Outreach for young people aged 10 to 25 years. And that's for people with mild to moderate AOD related issues. And the locations that they're providing those from are Adelaide, Elizabeth, Hindmarsh and Noarlunga. And I should have said at the outset too, that if you want to know more about more detail about what each of those services are providing, those organisations are providing. The Adelaide PHN service directory has just been recently updated, so that includes all the information about who the service providers are and a bit more detail about referral pathways and how to access the services and what's in scope and what's out. But also I would recommend that people look at the Know Your Options website and also go to the individual websites of each of the organisations to find out more about what they're actually providing. The other program that Mission Australia is being funded by us to provide is the Partners Toward Wellbeing, and that's for mild and or moderate comorbid mental health and AOD related issues. It's a partnership with SANDAS. It's looking at some of those population and priority groups that I mentioned a couple of slides ago, and the locations that they're providing those from are the Northwest Hub, Southern Hub, Outer Southern Spoke, Outreach, GPs, RHOs, and youth services. Uniting Communities through the StreetLink program are providing young people who are aged 10 to 25 years, but who are experiencing complex needs with services. And they're doing that from their New City complex and Southern and Northern Adelaide. Ngunnawal Unity through their harm minimisation team are providing services to Aboriginal and Torres Strait Islander people who are aged 15 years plus who are experiencing complex AOD issues. And they're doing that through their CBD, Northern and Southern Adelaide offices and services. Thorn Arbour Health, who's a new service provider, they're providing specific treatment service for LGBTIQ people who are experiencing AOD-related issues. And they're doing that on-site and through outreach services and support, and locations include Adelaide, Woodville and Outreach. PsychMed, who are providing the Matrix methamphetamine treatment program, and that's for people with significant substance use issues who are aged 18 years and plus, who are undergoing drug replacement therapy with a GP. And it includes methamphetamine or cocaine or combined with opioid use. And they're providing that through their Adelaide, Elizabeth, Hindmarsh and Noarlunga settings. And then we have Oars, who are through their Community Transitions Drug and Alcohol program, are providing services to people aged 18 plus who have been recently released from DCS custody or who are in contact with the criminal justice system. And the locations that they're offering that service from are Adelaide, Port Adelaide and Christie's Beach. One of the things that's been happening in the AOD sector over the last few years is a greater focus on monitoring and evaluation and ensuring that outcomes are being measured and reported on. And the Adelaide PHN, like the treatment service providers, like the sector, is also required to focus on its outcomes and identify what its outcomes are and report on those. And so in the short term, our outcomes include, for the AOD sector, include people across metropolitan Adelaide being able to access appropriate AOD treatment services, that our commission providers develop culturally appropriate services for Aboriginal and Torres Strait Islander people, that local workforce within the Adelaide PHN region has suitable cultural and clinical skills to address the health needs across that region, and that healthcare providers have an integrated approach to AOD treatment services. So that's the short term. And in the long term, we aim to ensure that people in the Adelaide PHN region are at decreased risk of harm associated with substance use. One of the things that we've done with our commission service providers is we've mandated that they use either the Australian Treatment Outcomes Profile and or the Alcohol and Drug Outcome Measure to measure client outcomes. And the reason why we've adopted the ATOP is that that's a consistent approach that DASA are taking, Country SA PHN are taking, and it's also a consistent approach across the country. The ATOP is a measure that's been developed and refined by Nick Linzeris and his group in southwestern Sydney, but people like Robert Ailey from Adelaide and other notable alumni from the AOD sector have been involved in developing the ATOP over the last few years. Its major limitation is that it has not been validated for use with Aboriginal and Torres Strait Islander people as yet. So as a countermeasure for that, Aboriginal and Torres Strait Islander services relying on the alcohol and drug outcome measure, which has been developed, or the ADOM, which was developed by Mataraki in New Zealand, and it has been validated for use, it has been validated as a culturally appropriate tool, certainly in New Zealand for use with Maori people, but Aboriginal and Torres Strait Islander services are using it in Australia as well. Both of those measures are designed to measure an overall decrease in the frequency of AOD use and an increase in a client's psychological health, physical health, and overall quality of life. And we've stipulated within our project schedules that they are the things that we would expect service providers to be demonstrating and reporting on to us as well. One of the other things that we've been working on is around data collection, and because we recognise that there is a diversity of data collection tools being used, we wanted to develop a standardised AOD data collection spreadsheet that can be used by all commissioned service providers, and that's the Adelaide PHN AOD Treatment Services Minimum Data Set. And what it does is it uses the AHW's Alcohol and Other Drug Treatment Service National Minimum Data Set and also records service activity, including referrals and service contacts, because recognising that the National Minimum Data Set doesn't do that. It also includes the ATOP items, the ADOM items, the K10 plus, and K5 items as well. And we're also concurrently developing a secure online data entry and collection portal. The data collection spreadsheet has just about been completed, and we will look to get that out to everyone that we've commissioned by next week. So that's it from me. Are there any questions or any clarification that people would like? And I guess, Sam, they'll be looking to use the chat function to do that.
The Q&A function, yep.
Q&A function, sorry, yep.
Yep. We just got a question from Scott Wilson.
Yes. Hi, Scott, how are you?
Who asks, hi, Alan, we were not given a choice of ADOM. We were told that we have to use the ATOP.
Okay. Who was that by?
Hey, would you be country PHN?
Country PHN.
Okay, yeah. We certainly recognise that with our service providers that I might just stop sharing the screen if that's okay. We recognise that ADOM was much more appropriate, and that Aboriginal services are already using the ADOM, so we thought that we would incorporate both. And that's maybe a conversation that you could have with Country SA PHN.
Thanks.
Okay. Sarah from SANDAS has asked for a link for the online AOD screening tools. What I might do, Alan, is include, I have popped that out on the e-news once, but what I might do is I'll include it in the email that's going to everyone who attended today as well. And then we might promote it again on the e-news because that is a good collection. So I'll make sure everyone gets that link.
And what I'd also do, Sam, is I had a meeting with Robert Ailey and Matthew Stevens from Adelaide Uni on Friday, and they are responsible for the Assist portal, which includes all the Assist tools, so including Youth Assist and the ICE Assist as well. So I can send you the link that they sent me because they've now got all of their manuals online as well in PDF version. So I think that's a really useful resource as well. So I'll send you the link to that.
Yep, I'm happy to share that. That would be great. Someone's asked if they can get a copy of the presentations. Perhaps what we'll do is if people are happy to share their presentations with the group, if they can flick them through to me and I'll pop them on the website.
Yep, you've already got mine anyway, Sam.
I do have yours. Yeah, I do have some people.
And and we're happy for that to be shared. So
okay, great. Excellent. Any more questions for Alan before we move on? Oh, okay, great. Thanks, Alan.
thank you.
And now we might hand straight over to Phoebe, who is from the Commonwealth Department of Health. If Phoebe is there.
Thanks, Sam. Can you hear me?
Yes, we can. Yep.
I would like to acknowledge and pay my respects to the traditional owners on the land in which we're meeting on today. So we're from Canberra and the Ngunnawal people. So I'd also like to thank SANDAS for the opportunity to present to you today and appreciate the time that you've all taken to come and hear us here. So we had a couple of things that we thought you might be interested in hearing from the Commonwealth on, and that's the drug and alcohol program and some of the measures under that. And you'll be aware of the new drug and alcohol treatment services maintenance funding that was announced in the budget. And we also wanted to talk to you as service providers around the impact of COVID on the sector to date and some of the ongoing impacts as well. We'll go into the drug and alcohol program overview for those who aren't aware. So the Australian government has committed more than 880 million over 4 years from 1 July 2020. And as you're probably aware that the state and territory governments are the primary funders of drug and alcohol investment. However, as part of our 880 million, we've got more than 690 over those 4 years for drug and alcohol treatment services and national leadership activity programs. And as part of that, we've got the 445, which is provided to PHNs around Australia to commission locally based treatment services. And in South Australia, you've got Adelaide PHN and the country SA who is speaking after us. Out of the 445 million as well, so quite a significant investment has been under the National Ice Action Strategy measure. And the funding through the drug and alcohol treatment services for that was provided through PHNs to provide coordinated health services through their services. We've also retained around $135 million for services with the national and statewide intake, of which we have a few directly or through our community grants hub as well, but we have the funding agreements directly with the sector. We've got one example where we have provided funding to the Salvation Army in South Australia, and they're delivering an Aboriginal outreach and comorbidity project, which aims to provide a safe and stable environment where the workers can undertake culturally sensitive casework with those Aboriginal and Torres Strait Islander clients who have experienced difficulty in accessing some mainstream services. This particular project provides 6 Indigenous specific beds for around 10 clients a year, between 12 and 20 weeks, and on-site support is provided 24 hours a day. We've also got a fair chunk of funding being provided through other budget measures. There was one particular one for South Australia, support for drug and alcohol misuse in South Australia. There was a health and hospitals program, which we refer to as the CHIP funding agreements. We've also had the increasing access to drug and alcohol treatment services in rural and remote areas, and that was provided through the PHNs to do work through that measure. We've also, just in terms of the newly announced drug and alcohol treatment service maintenance measure and the cashless debit card trial measures for AOD services in 4 sites around Australia. So as part of the kind of work that we do, we're, in terms of what we can do for you today, we would be keen to kind of hear from you on how some of these measures, have made an impact in South Australia, and always keen to hear feedback on how we can do things better. In terms of the treatment services maintenance measure, which you'll all be keen on, so that was to pretty much replace the social and community services supplementation that was provided. So there are impacts on those services that we do direct fund, and those also commissioned through the PHNs, but we'll go to those slides later on. So with the drug and alcohol treatment services measure, so it's only for across the next 2 years. And the administration, in terms of the funding variations, are still being finalised, and we'll get some further information out to the sector and to the peaks as soon as we can. Indexation or CPI, so that again we're hoping to include that in potentially the variations under the drug and alcohol treatment services maintenance measure, but further details will be provided once that's confirmed as well. We also wanted to talk to you today around and try and understand a bit better some of the impacts, particularly in light of the last few days for South Australia, but just the impact that the COVID-19 has had on your services, your workforce, and your clients. We try and keep abreast of some of the research and papers and just ad hoc information that's provided. So we know that the Matilda Centre and the NADA, the Peak in New South Wales, provided an editorial around the impacts of COVID, and that it pretty much outlined that people with and without substance use disorders have been disproportionately affected by COVID. We also were very interested in a piece that the Peaks undertook in terms of what the impact were on some of the services and your workforce. The Australian government, in response to the initial impact of COVID, provided a measure of 6 million just as a kind of boost to the activities that we were already undertaking, and providing additional funding through services such as Turning Point, who operate counselling online for us. We've also got some early intervention programs such as Hello Sunday Morning. We also provided some funding to Smart Recovery, who was a new organisation for us, and that was to kind of support the adaptation of their service to online service delivery model. So I'm sure some people in South Australia have used that Smart Recovery model. And we also provided some funding to the Matilda Centre and the Cracks in the Ice portals to do some new resources to particularly focus on those Australians impacted by COVID-19. So if you haven't already, it'd be good to check out their portals and the new resources that are available through there. There was also an amount provided to the ADF, the Alcohol and Drug Foundation. So they did a bit of a campaign, which you may have seen around Little Habits. So that was kind of a big kind of target, not targeted kind of campaign, which you may have seen through advertising. We've also got some policy work that we've been doing around the National Treatment Framework and the National Quality Framework. And we We've done some work with Alison Ritter from the University of New South Wales around the National Treatment Framework. With the quality framework, so you would have all been aware of the quality framework and the guiding principles within that, and the list of accreditation services that drug and alcohol treatment services were to meet. So be interested to hear your feedback on the quality framework. We're also doing a second round of mapping with the NCETA, so the National Centre for Education and Training on Addiction in South Australia, and one of the peak bodies in terms of updating in the National Quality Framework. Another one that you may be interested in is that we're also, the department, another area, but our department is has also engaged in CETA and to work and update the National Alcohol and Other Drug Workforce Development Strategy, and hopefully have a new workforce strategy by mid-2022. So we're conscious in all the work that we do, the impact on the drug and alcohol workforce, and particularly in kind of some of those regional and rural and remote areas, of which South Australia has as well. Another thing you might be interested in is the launch of the update of the alcohol treatment guidelines through University of Sydney, and with clinicians now having the latest evidence-based information on how to best treat people experiencing harms from alcohol use. And we can provide that link. So the uni will continue to work to promote the guidelines throughout the later half of this year. With the PHNs there today as well, so we're also looking at opportunities to promote these guidelines through all the PHNs, the 31 PHNs across Australia. So the other budget measure, aside from the SACS replacement, was the cashless debit card. So the government has committed up to 50 million over the next 4 years in the existing cashless debit sites. So that's Sejuna in South Australia, Bundaberg, Hervey Bay in Queensland, East Kimberley and Goldfields region in WA. So the additional support is in recognition of the effects of the CDC trial on the participants and people in the surrounding area with drug and alcohol issues. We're working with our colleagues at the Department of Social Services as well. We've also, the colleagues at Prime Minister and Cabinet, and we also work pretty closely with the National Indigenous Australians Agency as well. But we're working with relevant funding bodies and community organisations already in those areas, and how we can support drug and alcohol treatment, including outreach and support services to increase the accessibility and availability of drug and alcohol treatment, including culturally appropriate treatment for those trial participants. So we currently got a consultation procurement out, and we're hoping to provide some community consultation to inform the remainder of the funding, and working with state and territory peaks, our ARCHOs, state and territory governments and communities, so that they will all be important stakeholders in the consultation process. So yeah, there are kind of main points. So we were hoping to have a bit of time to have some questions, and we might have some questions for you guys, having you all there together. So we're, in terms of our department, so we're in the prevention and treatment section. So I've got a team here. We also, so we provide all the funding through the primary health networks, as well as those kind of direct contracts that I spoke about earlier. We've also got a team that looks after prevention and early intervention projects, and programs, so things like the local drug action teams, counselling online, the Hello Sunday Morning, and some resources for students and young people and teachers, and the Cracks in the Ice portal So yeah, happy to have some questions, and we might have some questions for you as well.
Great. Thanks, Phoebe. Is there any questions for Phoebe and her team there? Scott Wilson wants to know when consultations in Ceduna are likely to occur.
So we've got the procurement out for consultation. So we're hoping that will kind of be done and dusted in the next couple of weeks, and then we'll work with the consultant pretty closely and work out when the kind of timing for the 4 different sites, including Ceduna. So we can let Scott and also we'll be touching base with Michael as well in terms of the Ceduna.
Great.
Yeah, just a further question, like the procurement with the consultants, is that something that you know, service providers are able to have a look at, or is this just between you and or your department and some consultant? Because we run drug and alcohol services in Ceduna and we haven't actually heard anything about it.
Yeah, so we've gone to a panel to undertake this particular piece of work, but it would be expected that the consultant would work with the community and those already providing services in Ceduna as well, Scott.
And when are they doing that?
So we've only just currently gone out to the panel, and then we'll have yeah, and then so it'll be a couple of weeks, and then in terms of getting a funding agreement out, and then it'll probably commence. What are we in now? July. So yeah, I dare say there'll be community consultations starting in August, September.
Okay, great, excellent. Anyone else got any questions for Phoebe at the moment? Nope, doesn't seem like it. Great, thanks so much, Phoebe, for your time this morning. Great, excellent. We might move on. The next person we've got is Chloe from Country SAPHN. Chloe, if you're there.
Yeah, I'll just put my screen up. So was that showing?
Yes, that's great. Yeah.
All right. So cool. I'm Chloe. I'm representing Country SA Primary Health Network today. I'm currently coordinating the AOD portfolio. So today I'm just going to go through 4 key points that kind of outline what we've been doing over the last 6 to 12 months and where we plan on heading. So they're going to include collaborative planning, market review and needs analysis, our AOD tender, and the successful applicants of the tender process. Okay, so collaborative planning across the main commissioning bodies. We underwent a collaborative planning approach as previously the AOD sector had been quite disjointed without communication between providers or commissioning bodies. As mentioned earlier by Alan, we joined up with APHN and DASA to undertake a statewide needs assessment in addition to rolling out the tender opportunities at a similar time. This was to ensure consistency across the commissioning process. Overall, this led to increased transparency, a reduction in program duplication, ensuring all regions are serviced by at least one of the commissioning bodies, better information transfer and assistance, and the tender process was implemented at the same time across all the organisations. So sorry, I've lost my place. So with the needs assessment, we used this to gather information to put towards the tender assessments to know exactly what we wanted and the key points we should be looking for. So what we found were the key at-risk populations were Aboriginal people, youth, cold populations and older males. Areas of low service access and increased need were the APY lands, Port Augusta, outback South Australia, and the Riverlands, specifically Berry and Renmark. With drug trends, we noticed a change during COVID-19, and that there was an increase in use in cannabis and alcohol, and a decrease in the use of MDMA, cocaine, and ketamine. Likewise, the COVID-19 arrival also brought changes around for co-occurring issues and comorbidity, where we saw increased levels of stress, domestic violence, child safety issues, social isolation, and suicidality. So all of these points were definitely taken into context when we were assessing the tender applications. Okay. So we utilised an open tender process as a way to reshape the field and allow for other providers to apply to ensure we had the best services being received by the regions. The scope of the activity could range from low intensity to complex clinical care. Under our guidelines, proposed projects were required to include either interventions to reduce harm, interventions to screen, assess and coordinate, or intensive interventions. These could include brief interventions, counselling, case management and care coordination, and non-residential rehab. Sorry. We additionally required providers to ensure all treatment was underpinned by 6 principles as outlined in the national framework. And these included the person-centred care, equitable and accessible care, evidence-informed, culturally responsive, holistic and coordinated, and non-judgmental, non-stigmatising and non-discriminatory. Furthermore, all providers were required to work within a stepped model of care as shown in the diagram there. So our tender opened in November and remained open for around about a month. From previous funding streams, we had 2 streams remaining. However, their timeframes differed. Therefore, providers could apply for either core funding, innovative funding, or both. The core funding was available for a period of 2 years and was originally the NGOT GP funding, while the innovative funding was only available for 1 year and was originally the National ICE Action Strategy money. Overall, we had 17 organisations apply, with applications in excess of the funding available. 7 were successful under the core funding stream and 6 under the innovative stream. Overall, 8 services were targeting mainstream populations and 5 were Aboriginal specific programs. So our successful funding applicants for the regions are as follows. For the Air Far North, we have Life Without Barriers, Umina Jukada, West Coast Youth Community Support, and Aboriginal Drug and Alcohol Council. For the Barossa Hills Fleurieu, we have Sonda and Baptist Care. For the Limestone Coast, we have Baptist Care and Pangula. For the Flinders Upper North, we have Country and Outback Health, Mission Australia, and Aboriginal Drug and Alcohol Council. For York and Northern, we have Country and Outback Health. And for Riverland, Mallee, Coorong, we have Mission Australia, Baptist Care, and Aboriginal Sobriety Group. So our next steps in the AOD sector is predominantly to enhance communication across AOD providers and across the AOD funding bodies, just to ensure that information is being transferred and that everyone knows what other providers are offering. We've also taken to implementing the Australian Treatment Outcomes Profile, and this has become mandatory across all service providers. This is in addition to the AOD minimal data set. And the final point is, I can't see what it says, the provision of support and resources to support AOD delivery, which is pretty self-explanatory. And yep, that's me.
Great, thank you, Chloe. Did anyone have any questions for Chloe? Nothing popping up in the chat at the minute. That's great. It's always hard being the second PHN because then the first PHN always like steals your thunder with lots of
yeah, I was watching, it's like, no, that's my slide. That's my slide. So mine was very brief.
Yes, no, that's absolutely fine. You've got us back on time, which is great. Oh, Scott's just popped up in the chat, I think reiterating his question of Alan about the ATOP versus the ADOM. I don't know whether you heard that earlier.
I did. Maybe if I will have a talk with Scott afterwards, because I do know that the ATOP hasn't been, I can't think of the word. Validated for Aboriginal populations, and I don't believe that contract's been executed yet. So we can definitely discuss other options.
Okay, great. Yep, Scott says that's fine. If you could, he'll touch base with you perhaps afterwards.
Awesome.
Great. Any other questions for Chloe before we move on?
Sorry, Sam, just a quick thing. Chloe,
Sure.
if you wanted to contact me, I can have a chat to you about the ADOM as well. We can have a separate conversation if you like. Okay?
Yeah, no worries.
Thanks.
Awesome. Thanks.
Great. Excellent. Excellent. Well, we're back on time then. That's a really good outcome. Next, we have Trisha from Oars Community Transitions. If Trisha's there, hopefully. Trisha, are you there? Nope, might have popped off to get a coffee. Okay. Is Ben, do you happen to be ready? I'm jumping on you 10 minutes early now, but
that's fine, Sam.
Oh,
I'm here.
Excellent. Thanks, Ben. If we can have
No worries. I'll just share my screen with you. I'll try and share my screen with you.
Something with your camera too. We can't see you.
How is that?
Oh, there we go. Yep, perfect.
G'day, everyone. Rightio. Can you see my presentation, Sam?
Yes, we can.
Definitely get into the first slide.
Slideshow.
Sorry, I'll just scroll back. There we go. Good morning, folks, and a cold and blustery welcome from Paramount Country in the Adelaide Hills, where I am. Just want to acknowledge that this has always been and always will be Aboriginal land. I'm very grateful to be stuck at home in such a beautiful place. I'm here to talk to you about the Tumbling program. Tumbling is a program that Baptist Care has been running across South Australia for about a dozen years now. Tumbling's a word from the Ngarrindjeri language, which means awaken and live. And this is really the outcome that we're trying to help young people achieve, to become more awake and alive. For those of you who haven't heard of the Tumbling program before, it's an outreach adventure therapy based program aimed at young people aged 13 to 18 who are really in that pre-contemplative or contemplative stage of change around their drug and alcohol use. We've been funded to deliver Tumbling through the Country SA PHN in the Barossa Hills Fleurieu region for the current financial year. Also the Riverland Mallee Coorong region in the current financial year, and in the Limestone Coast for the next 2 years. Just a quick insight into some of the foundational thinking which underpins our practice with young people. We have a working assumption that young people who can discover and experience a connection with themselves, others, the natural environment, and something bigger than themselves, and develop and maintain their capacity to build positive, healthy relationships, will be more likely to reduce the risk of harm associated with drug and alcohol use. So in practice, what that means is us getting face-to-face with young people, connecting them with other young people and other people in their community, including their family members, significant others, but also peers and mentors, and getting out and doing stuff together. We're big believers in experiential learning, social learning. Our experience is that young people who sit for too long tend to disengage, so we try to keep people moving and interacting. So what constitutes tumbling? There are a couple of different streams. The one which is probably our linchpin is the group adventure therapy program, which consists of weekly sessions for groups of 8 to 10 young people. We typically run them over a course of 9 weeks or a school term. There are base camp sessions, which are generally 2 to 3 hours long, working with groups of young people. Summit sessions where we actually get out and about and do the adventure-based stuff. So bushwalking, rock climbing, abseiling, caving, kayaking, either as day activities or overnight camps, which all lead up to a peak experience, which is a 3-day, 2-night camp. All of those young people who take part in group adventure therapy do have access to one-to-one support with a tumbling case manager. And then there's a celebration event at the end of that program, which includes family members and significant others. Other streams include the youth intensive interventions, which are basically weekly one-to-one sessions with a tumbling case manager. Case managers reach out to individuals in the community and really deliver a modified version of the base camp sessions. We also run school-based workshops, which generally last for 75 to 90 minutes. We can run these at schools, as the name implies, but also in community settings. And they're really about exploring with young people how they make choices and decisions. People are in the thick of adolescence at that age, and one of the things is they're transitioning from being at an age where someone else typically made a whole lot of decisions for them to adulthood where they're going to be able to make their own decisions. So we use that opportunity to explore with young people how do you do this thing called decision making and making choices, and what are the things that influence how you go about this, and including the decisions you're making around drugs and alcohol. And we also work with family members and significant others of young people who are engaged either in the group adventure therapy or the youth intervention sessions, so that those people have visibility of the journeys that young people are going on during their engagement with tumbling. As far as referrals go, we certainly reach out to high-need, high-impact schools within each of the regions. We've got bookings for term 3 and term 4 of this financial year pretty much locked in all regions. We're hoping to begin working more closely with the headspace centres in each of the regions we've been funded to work in. Currently in conversation with Mount Murray Bridge and Mount Barker and Victor Harbour around co-location of tumbling case managers in their centres, and we look forward to this kind of conversation in Mount Gambier. Aboriginal community controlled health services in our regions, Murundi and Pangula, and of course referrals from GPs and other AOD and health service providers who work with young people. It would be remiss of me not to just quickly mention our partner program, Tumble and Farm, which is not actually funded through the country SAPHN, but directly through Department of Health. But certainly when we're working with young people who are more in a pre-action or action stage of change that we might engage with in a Tumble and program setting, there's the opportunity of referral to Baptist Care's residential rehab program, which is Tumble and Farm, located in the Mount Lofty region ranges. So it's a statewide service. So we hope that young people taking part in tumbling or any other programs that are delivered by any of the agencies across the state, we feel like a stint of resi rehab would be worthwhile for them. Please feel free to contact us in relation to coming to Tumble and Farm. If you've got any questions or further information, there are my contact details. And yeah, thanks for your time. Look forward to keeping in touch over the coming year.
Excellent.
Thanks, Sam.
Thanks, Ben. Did anyone have any questions for Ben? Nothing popping up in the chat that I can see. No. Great. Excellent. I believe we now have Trisha, who was distracted by something COVID related, which is kind of the story of our lives at the moment. So we'll forgive. Thanks, Trisha. I'll hand over to you.
Thanks. I'll just get it up. Okay, can everyone see that? Hopefully they can. and I am the team manager within Oz Communities Transitions, overseeing our alcohol and other drugs program. All right, let's get started. First of all, I want to acknowledge, do an acknowledgement of country. We recognise that, oh, hang on, I've got to get this off. Wait up. We recognise that the land on which we meet, live and learn has considerable natural and cultural heritage, including thousands of years of traditional ownership by Aboriginal people. And we pay respects to elders past, present and emerging. And I am currently on Kaurna land in Adelaide. All right, so here we've got lots of bubbles and the evolution of Oz Community Transitions as it stands today. So we were established in 1887 as Prisoners Aid Association, and what that would make us 134 years old. And we've moved through now. In 2010, we transitioned into Oz Community Transitions. And I guess what I really wanted to highlight within this slide is our statement of purpose, and that is enhancing community wellbeing through reduced offending and victimisation. And I really want to underline reduced offending and victimisation, because that is at the core of what we do across all programs, really trying to reduce recidivism within and reduce harm to the community as well. All right. So this brings us to our CHASM service delivery model, which is our alcohol and other drug program funded by PHN. CHASM is an acronym that stands for Counselling, Health and Substance Management. The CHASM program delivers person-centred alcohol and other drug treatment interventions to people aged 18 or older with a sentence that has partly been attributed to substance misuse and are exiting or have been in contact with the South Australian criminal justice system. So we've got a few different quadrants here, and CHASM works to support people in contact with the criminal justice system, their families and significant others to access appropriate alcohol and other drug services that are person-centred based on their individual needs, and be supported to meet their treatment goals that work to reduce their substance use and associated harms that improve their health and social functioning whilst having a positive experience within the service. So when we're talking about the service, we're not just talking about the one-to-one counselling, we are talking about the smart recovery and relapse prevention and or drug awareness group options, which coexist with the case management, and all that can kind of happen concurrently. And exit planning is also incorporated into that from the outset, as we're planning on clients eventually leaving us, hopefully in a better state than what they arrived in. Okay, so what does that look like from our staged model perspective? So referral and intake. So within referral and intake, we have clients can actually refer themselves, or we can get referrals from any organisation, DCS, courts, non-government, government, anywhere really. And we're assessing their suitability as in that criminogenic cohort that we're looking for. If they haven't got that need, then we would refer out. But generally speaking, most of our clients that do come to us have had some engagement with the criminal justice system. And we're looking to explore comorbidities. We're looking to explore current drug use. We're looking to explore motivation. And we're looking to triage them into the most appropriate treatment type for them individually. So within that, often that starts with building some motivation, because a lot of our clients are coerced to come into counselling from perhaps corrections or the courts. And so we're working with them to try and build that motivation in that first 3 sessions. And we do offer that as a group, and I'll speak to that towards the end of the presentation, or one-to-one, depending on the client's capacity to engage in a group setting. We're doing some screening in this stage as well, and we're really measuring readiness for change and drug use, where it's at, where it's been, all that sort of stuff, as well as mental health, which sits along concurrently. So provided the client's motivation has increased and their willingness to engage is still there, we would continue on, and we would enter into the 3rd stage, which is your treatment planning and counselling. This is roughly around 15 sessions. However, I want to identify that treatment planning really happens from the outset at referral and intake. We are constantly building towards that, and we utilise a tool within the Good Lives model to support that, which focuses on the criminogenic needs. And I'll get to that in the next slide. So we're constantly screening, constantly evaluating, constantly reflecting on those goals and what's important to the client as part of their counselling journey within the criminogenic space. Working through, provided we've maintained some abstinence, we would then look towards review and exit planning, entering into a relapse prevention focus of counselling, if that's the client's goal. We're looking at high-risk situations that may put them into relapse. We're looking at all the standard counselling tools that would go with relapse prevention counselling, and we are putting those supports in place should they wish to re-engage at a later date, as well as making referrals the whole way through as appropriate and engaging with case management with the client. From there, we would move the client through to our post-treatment follow-up register, and that happens at 3, 6 and 12-month intervals, provided the client is engaging. The client can also contact us back at any given point, and we often hear back from clients letting us know that they're either progressing really well or want a few refresher sessions, or maybe need to fully re-engage. Maybe they need some help with some gambling harm related counselling. We can support with all of that as well. So I mentioned our case planning, and it really does. The Good Lives model underpins our case planning across the organisation, not just within the drug and alcohol team, but it is a specific way of working with offenders. It is a strengths-based approach, and it is a tool that supports the development of case planning that directly looks at the client's previous offending behaviours and explores them. It looks at opportunities to meet the client's needs in more pro-social ways. Often clients are acting in opposition to their core values when engaging in offending behaviours, and the GLM allows the client and their worker to explore alternatives to their story with the aim to reduce harm to themselves and others. So what we've got here is a big hexagon in the middle that says GLM. So that sits at the core of the work that we do. And the outer hexagons all reflect what influences and shapes the CBT strengths-based, holistic and person-centred model. Offender rehabilitation and working in opposition to offending behaviours sits firmly within this case planning process. It is unique to each client, fluid and changing. So this next slide really sits quite well with what we do at Oars. The duty of society does not end with a prisoner's release. There should therefore be governmental or private agencies capable of lending the released prisoner efficient aftercare directed towards the lessening of prejudice against him or her and towards his or her social rehabilitation. And that's what we really do at Oars. We're really looking to provide that through care from the prisons into the community and ensure that that aftercare results in reduced recidivism and that social rehabilitation. So our final slide identifies where our services are held, and the groups that I mentioned earlier, the Smart Recovery groups, are also held within these 3 locations, with the Smart Recovery at the Pilgrim Church in the city, in Flinders Street. Port Adelaide, it's in Church Street at the Port Adelaide Library, and Christie's Beach is at our Christie's Beach office. And if you want any further detail around that, you can contact myself or my manager, Kylie, on the emails below to find out more detail around that. And our drug awareness group that I mentioned in the beginning, that is also held at our Christie's Beach and the Port Adelaide Library locations, and clients are referred into that at intake. So anyone can drop in and out of the Smart Recovery, but our drug awareness is referral through intake. And that's the end of the presentation.
Excellent. Thank you, Tricia. We've just got one question before you run away, just from Vita. Hello, Vita. She would like to know, just to clarify eligibility for Oars, community transitions used to include those at risk of contact with the criminal justice system. Is it now exclusive to those currently involved in the criminal justice system?
So we would still take clients on that are at risk, I believe. I haven't had confirmation 100% on that from PHN. I need to reach out for that, because it does say people currently involved with the criminal justice system in South Australia. We are currently taking clients at risk until I have had that confirmed.
Okay, great. So maybe if people are unsure about a particular client, just get in contact and
yeah, absolutely,
have a chat about that. Okay, great. Excellent. Thank you very much, Tricia. All right, we are bang on time for morning tea. Well done, everyone. That's great. Oh, hang on. Just another question, Tricia, before you run away. I apologise, I just missed it. From Tanner, just wanting to ask what the age criteria is.
Anyone over 18.
Over 18, great.
Yeah.
Excellent. All right, well, morning tea time. I did have a 20-minute tea break, but maybe we'll make it a 15-minute tea break. Not trying to be miserly, but you know, we'll be able to move everything along. And since we're not all in the same room having lots of conversations, I think that's probably the way to go. So 15 minutes. Can we meet back here at 10:45? Grab a coffee, go to the loo, go pat the dog, whatever you need to do, and we'll see you back here at 10:45. Thanks, everyone. Okay, great. Welcome back, everybody. Hope you've got your coffee and something naughty to eat for morning tea, perhaps, or something healthy to eat. I should be encouraging healthy habits. So hope we're all ready to go. Next up, I'm hoping she's back because I know she's wrangling some kids with online learning today, so I don't envy her at all. But is Michelle Edmondson there?
Definitely here and definitely surviving, so we're still good.
Excellent. Thanks, Michelle.
No worries.
I'll let you go.
All right, hang on. There we go. Alrighty, I'm hoping everyone can see that. So my name is Michelle Edmondson and I am the Program Manager for the Alcohol and Other Drug team with Life Without Barriers. And I'd like to start first by taking a moment to acknowledge the traditional custodians of the lands from which I'm on today, which is the Kaurna people. And I'd also like to acknowledge the many traditional custodians of the Far West region for the program that we're talking about today. I'd like to pay my respects to elders past, present and emerging. And I'd like to acknowledge that it always was and always will be Aboriginal land. So Life Without Barriers runs a number of drug and alcohol programs throughout the state, but the one that I'm going to be talking to you today about is the Country SA PHN funded program, which is operating out of Ceduna. This is an assertive case management, outreach and therapeutic counselling program that it's running to approximately a 96% Aboriginal demographic client group. We've recently, we've been running the program for a number of years in that region, and we've recently received the renewal of that funding, which is really exciting for us. So what does the service look like? So it's currently an evidence-based voluntary counselling, case management and outreach services for those aged 12 and above in that region. We service the local 4 communities, which consist of Coonabar, Yalata, Scodesco and Oak Valley, and the 9 smaller homeland communities as well in that far west region of South Australia. The services, whilst they're that counselling nature, it's a very unique program. It doesn't look like our typically run outpatient counselling program. So the services will occur where clients feel comfortable and familiar with the environment, and we take great pride in ensuring that the program is a culturally appropriate service and that clients feel comfortable and safe to access it. The first visits that we run with clients often focus on building rapport, and we really adopt and embrace the narrative approach to the service region and looking at, sort of acknowledging the client's story and the power in that. Along with the voluntary counselling, case management and outreach, we also participate in a lot of cultural activities in that region. And this is really important for us in our service delivery because it ensures that we are part of community and that we're understanding community need and that clients can access us in an appropriate way as well. Along with that, we're also running educational workshops. So we're out in community delivering either harm minimisation or educational focused sessions around AOD, and they may consist of a day to 4 days to a week, depending on that community need. Most recently, we've been out to Oak Valley and run an educational workshop with the park rangers out there, which was fantastic. And we've also partnered with the local traditional healers, the Nuncrees, to do some workshops in Ceduna as well. We work with a very high complex and comorbid client group, and the work that we do wouldn't be possible without our partnerships and our stakeholder relationships that we have in the region. So we are based in Ceduna at the Ceduna Red Cross Community Hub, which is a fantastic location. This ensures that we've got a really streamlined referral pathway to the Street Beat program that runs out of there, and that clients can access multiple services while they come out and see us as well. Due to the high physical needs of clients that we've got in this region, we have some really great informal relationships with local health services, such as the Ceduna Coonabar Aboriginal Health Service, the Talawan Health Service, and the Ceduna Hospital. That's through our relationship with the DASA nurse, and of course the community paramedics. Those relationships could look like us visiting the community paramedics daily to ensure that our clients are receiving healthcare that they need. And it could also be that the health and wellbeing workers are touching base with us around, the clients that we're working with. We have really strong formal relationships with ADAC and the Yalata Anangu Corporation. ADAC obviously have the day centre out in Ceduna, and so we wouldn't be able to operate without our relationship with them, because we obviously touch base with them at the day centre, and we see clients while they're getting breakfast. We have that sort of informal meet and greet with clients, which gets them to know us to know them, and it ensures that they can access that service again in a culturally safe and appropriate venue. We're members of the Vulnerable Persons Framework out in Ceduna and the Frequent Services User Groups, and we're also a member of the Ceduna Alcohol Alliance group. We're proud and really embrace our relationships with our nunkeries and the traditional healers in that region. And we look to seek cultural guidance for everything that we do out there, just again to ensure that we're doing in a culturally appropriate service. There's a really strong recognition of family out in Ceduna and the importance of working alongside family as well as the loved one who's experiencing the substance use issue. And so we hold regular coffee and yarn sessions. This looks like family dropping in, and they can yarn about what's going on for them and their loved one. We can work on strategies to help them support their loved one, or help them with strategies to manage their own concerns as well. How you can refer into the program. We largely take self-referrals. Word of mouth in community sees a lot of people just approaching us by themselves to say that they need help. We take a lot of referrals through community and family members who might have someone that they're aware of that would like some help from us. But we also take a lot of referrals through our existing relationships with our stakeholders. Referrals can be made either through the email that's up on the screen, so the aod.counsellor@lwb, or we can take them via phone call as well. And I know that the clinician on the ground also takes them direct through her. So there's quite a variety of pathways that someone can access our program. I feel like I've just spoken really fast, and I apologise if people are like, whoa.
That's okay. I never mind running under time, so it's all okay. Does anyone have any questions for Michelle or want her to go over anything? No? It's great to hear about what's happening in some of the country regions. We don't always get to hear about that. It's maybe one of the benefits of running things online is that we've had more engagement with our country services. No, doesn't look like any questions. All right, great.
I'll be online if anything does pop up.
Excellent. Thanks, Michelle. Thanks for coming along. All right. Joe in Port Lincoln, are you there?
Hello, I am. I'll just work out how to share this screen again.
Excellent. Great. All good. Thanks, Joe.
Excellent. Hey, everyone. Thank you for having us. We are excited to be here. We'd like to respectfully acknowledge past and present traditional owners of the land on which we're meeting today, which is of the Bargalla people. We acknowledge the living culture and unique role of Aboriginal people in the life of our regions. And we also acknowledge the traditional owners of country throughout Australia, their spiritual heritage, living culture, and our walk together towards reconciliation. And I just would like to pay particular mention to Nao, Wirangi, Mooning and Gugutha communities who we work across the region with. So I am excited to be talking about the Port Lincoln Healing Circles Day Centre. We were successful in gaining funding under the National Ice Action Strategy to build on our existing clinical and therapeutic AOD treatment services, to deliver a range of interventions, including but not limited to earlier intervention, targeting post-acute withdrawal support and relapse prevention, care coordination and after-hours service delivery, which is really popular in our country region for confidentiality, but also distance. People are travelling 100, 200, 300 k's to access services, and so being able to come after hours for them seems to be of benefit. Our new service is based on a day centre model of care, and it's delivered in partnership with Port Lincoln Aboriginal Health Services and Port Lincoln Aboriginal Community Council. And we really need to acknowledge ADAC for their support in the developing of this model for our region in the planning stages, which included the voices of so many people in our community through forums over the last 5 years that were heavily supported by SANDAS. We're also really excited to be working alongside SAMRI as part of this project with the novel interventions into methamphetamine use Aboriginal communities research project that's continuing. And so they'll be a big part of service delivery and supporting us to ensure we're capturing that evidence-informed resource and building on strategies to intervene. So we are proposing and will be delivering an outreach healing centre that's client-centred, culturally safe and available for anyone impacted by the harmful effects of misuse of alcohol and other drugs in the Lower Eyre Peninsula. It'll involve support and care coordination for any new clients entering the AOD system, and we felt that was really important. That'll be part of our existing services. People will be able to access through a variety of means, contacting our office, and then they'll be provided with options, support and service availability right across the region, not just ours, but we'll make sure all services are promoted because we have clients that move in and out of our region quite frequently. So kind of a catchment base where people, family, friends and people wanting to access services can get that information. One of these services will be utilising an evidence-informed framework and baseline screening and triage tools. Why are we doing this? So why a day centre? Really because it came out of the voice over and over and over again of our community. Ongoing feedback from individuals, family and friends of those impacted by AOD misuse was that meaningful engagement activities in our community is what's needed. People always having to leave our region to access these services wasn't suitable or helpful in their whole of life journeys. We're also really worried as a community about the harms we're seeing from AOD misuse, including much younger presentations than we've probably ever seen before. And collectively, Port Lincoln Aboriginal Health, Port Lincoln Aboriginal Community Council and West Coast aim to reduce these harms to some extent with the opening of the Port Lincoln Healing Circles Day Centre on the grounds of Mallee Park, operating 3 days a week. We'll do this working alongside our community and with peer workers employed within the program, alongside AOD clinicians, Aboriginal health staff and medical staff. The location's been really specifically selected to allow for outside nature activities, cultural cooking and other relevant activities to be part of the program as a whole, and as a safe space for all in our community. Those with lived and living experience have continually fed back as part of program planning that meaningful activities alongside therapeutic and clinical supports must be a part of any service delivery offered. And within an Aboriginal context, opportunity to connect culturally was extremely important. We'll incorporate a range of supports and activities, including partnering with other agencies to support facilitation of person-centred recovery within the client's whole of life environment. So this will include life skills and other engagement programs. We know that normalised support structures are what makes the real difference in the lives of those impacted by the harmful effects of substance misuse. And so we'll incorporate family and friends support as well. And we were fortunate to recently been successful in the ADF Family and Friends funding round. So it will be included as part of service delivery now. We'll offer a range of programs. So there'll be opportunity for people to drop in. So the drop-in services will have health checks, things like that, but we'll also have formalised evidence-based programs and a range of programs that will suit everyone. So the service will be open for anybody over 15, and obviously we'll run that really carefully. We're fortunate with the site that we've picked that we can run youth programs in one area and adult programs in another. So we'll be running a range of different programs, but the baseline of that will be a 12-week relapse prevention program to at-risk community members, which will include a separate youth program as well. We'll also be delivering deadly thinking, smart recovery will be offered, a DV perpetrators program, a life skills program. We know that trauma and grieving is something that's impacting our community as a whole. So seasons of growth will be offered. We have a qualified art therapist who will be delivering art therapy programs, hepatitis C awareness programs, and safer injecting and a harm minimisation program, because over the last probably 8 years, we've seen rising rates of both HIV and Hep C in this region. So we felt it was really important to make sure that was included as part of the day centre model. Referrals are self-referral for the majority of our program and always have been. However, we also take formal referrals and work in partnership and in a stepped up, stepped down care model with GPs and DASA. We also do support mandated referrals through the courts, corrections and DCP. Headspace and the schools are referral points, and we're currently working with the school to embed the program that will be offered to young people so it can be part of curriculum. We also work really closely with the mental health team here. Thank you from the Healing Circles Day Centre team in Port Langdon.
Great, thanks, Jo. Sounds like a great program, and you're something that the community has been calling for a long time. In fact, I've been at some of those community meetings myself, and I've literally heard those voices talking about the need for a day centre and somewhere for people to go that feels a bit more casual and they can connect with, and to hear that it's happening at Mallee Park, where it's already quite a community hub there, I believe. So yeah, excellent. Well done. Thank you, Jo. Any questions for Jo before I move on? Haven't seen anything pop up in the chat, but I think we're all good. All right. Do we have Michelle Spudic from DASA? Excellent. Hi, Michelle.
Hello. Hello, everyone. Similarly to Jo, I just need to figure out how to share my screen, so just bear with me.
That's all right. Great, we can see that.
I can see that. Excellent. All right, so today I'll just, firstly, I'll explain what I've been doing. So, because a lot of you know me from different roles. So I'm actually currently, probably for the last 6 or 7 months, been the project coordinator of across the COVID-19 funding that we've received in DASA. So that's what I'll be presenting on today and focusing on today is, which is, you know, it's a significant shift for us here. Even though we have done work with comorbidities and specifically mental health focus, this is a big area for us and a really, really big opportunity to move to something a bit more focused, and particularly for those of you that are familiar with the mental health services plan that's come out recently. That's also, you know, our projects are sort of in line with that scope and the aims of that. So they sort of started from keyly with what we noticed with the COVID-19 pandemic and how it was affecting clients. So what we noticed and the aim of the whole projects, which I'll go into in more detail, was actually to reduce those impacts of COVID-19 on what we know, how it's impacting on alcohol and other drug use. And that includes keeping an eye on, you know, any trends or any changes, because even though we have an indicator early on of what's happening, obviously some of those things can change over time. But what we also did notice was that there was an impact on hospital emergency department admissions and inpatient services. So there was an increased demand for that during the COVID-19 lockdowns and the pandemic in general. So what we actually did was that the Office of the Chief Psychiatrist we've been fortunate enough to be funded for a series of projects that were in response to an increased demand for support from the community. So what we noticed and what was coming out from research and data was that there was an increased demand in a lot of areas for people in the community for alcohol and other drug use, even though, you know, potentially looking at some data, you know, broadly, it may look like there may not be a significant impact. So if you look at the wastewater data for alcohol use, particularly, it's sort of plateaued out for the whole of the community in SA. But what we know is that our client cohort, or people who have, you know, potentially dependence issues with alcohol use, they do tend to be struggling a bit more and maybe potentially either drinking more and more frequently and more often and in larger quantities, but definitely looking for more support with that. So we noticed there was an increased demand for the phone line, keyly the ADIS phone line, from people seeking assistance, counselling and support. That was from individuals themselves, but also a big proportion of people seeking that support for their family and significant others as well. Also, there was a demand for inpatient withdrawal management that increased as well. And that sort of coincided with the increased hospital transfers as well, that were mostly coming from emergency departments. Because what we did notice with the data was that the emergency department presentations in Metro Adelaide particularly had increased about 8.5% across the board. And that was for anyone presenting for an alcohol or other drug issue. So that was people presenting at the emergency department, and when they were triaged, it was actually identified that they were presenting specifically for an alcohol or other drug concern. Could be anything from a physical injury to, you know, potentially a psychiatric issue, and anything in between. But that definitely increased. So for some hospitals, that increased quite significantly. So for the Lowell Mac, for example, that's more around 34% increase from following the COVID-19 initial lockdown and pandemic outbreak. So more or less what we had an opportunity to respond to this early on. So rather than waiting to see if there was going to be increased demand or increased, you know, potential harms for the community, we had an opportunity to have early intervention. So what we did was that when we actually developed these projects and we were looking at how best to respond to this demand in the community and how best to provide these early intervention responses, we did quite a lot of research in order to develop that and to develop how best to respond initially. And, you know, as all of you know, with projects, you can't get this 100% right, but part of this is getting as much information and research to inform that and guide that, and then learning ongoing and learning ways that you can improve that service delivery. And because these were all pilots, they were all initially implemented as short-term projects, most of them 6 months. It was sort of important to get as much of that data initially. So the key data that sort of shaped our response was the health needs assessment, which was developed by DASA. And from that health needs assessment, we identified the highest areas of demand. So where we were seeing this increased demand, which the northern areas were the really, really key standout for that, as well as, you know, far south, so sort of the Aldinga region as well, and also some areas in the Western Adelaide. So they were sort of seen as the really high need areas, but north really was a standout for that. Also, what we looked at was, we did the Sobering Up Services Review, which some of you may be familiar with. We looked at service utilisation data and the wait list. So that included looking at the Addis phone line utilisation, because as we said, there was an increased demand with that, and that was quite a standout. That was quite significant. And so therefore the wait time for response to phone calls increased as well. We also looked at outpatient appointment utilisations, and that was with non-government organisations as well as our own, and realised there was an increased demand for that. Also, the utilisation of referrals and the quality and quantity of those referrals, we also sort of established, including GP referrals and also referrals in and out from mental health services. As well as that, as I mentioned before, the hospital presentation data, we shaped this as well, and the SA wastewater analysis. And then also there were national data sources that also gave us some indication on the impacts of COVID for the community that we're working with. So that was the Keeley, the ADAPT study was actually quite a good insight, because the data sources in relation to COVID in Australia, as a lot of you would know, is pretty thin on the ground for drug users. So the ADAPT study was a really, really important resource for us to look at and utilise and still keep track of, you know, how those trends are progressing, as well as the IDRS as well for national and local data for the IDRS. And then we established key performance indicators and also reviewed our current ones. So from that helped us determine our current service establishment, and also how we could best respond to those, and develop key performance indicators that were more on point and helped us build our existing service delivery where possible, because they were short-term projects. So rather than, we didn't have the luxury of creating projects that were completely new and something that would have required, you know, a whole establishment of a new team, new systems, new data systems, those kind of things. We had to build on the existing service delivery where possible, however, still responding to all those data requirements and the trends we were seeing out in the community in order to respond to them best. So that required a little bit of updating our data systems, which is can be more of the time-consuming aspect of establishing, you know, six projects can be quite difficult, but we actually managed to do that in order to make sure that what we're actually doing on the ground was actually being reflected and able to be reported on accurately, because that's really important, because we know the work's being done on the ground, but actually, as you know, reporting that effectively is really important. So that included planning how we're going to report on the outcomes and evaluating the initiatives. And because these 6 projects were sort of a pilot, the reporting was probably more intensive than what we'd normally do or what we'll be doing on an ongoing basis, because it was sort of really, I feel like it was really, well, imperative to show the Office of the Chief Psychiatrist and also, you know, our existing directors and staff and managers, to show that we were on track and that we were responding and that it was actually effective, and that we were actually making a difference and actually meeting that demand from the community in successful measures. So yeah, that required regular reports monthly to the mental health services. It's called the Oversight Committee. So there's, you know, key important people, including Treasury, on that committee, and that reporting really paid off for us, providing that more in-depth, detailed reporting, because it was able to show and indicate how we were tracking with these projects, and therefore it actually enabled us to secure further ongoing funding, including some 12-month funding and some ongoing funding for some projects. So the projects we implemented until the end of June were 6 key ones, which was the Addis phone line expansion, the expansion of the consultation liaison service, which is the nurses, specialist nurses in hospitals that provide alcohol and other drug capacity building for staff, but also engage with individuals in that more in-depth support for alcohol and other drug issues while they're in hospital. And they link in with existing AOD services and provide a lot of referrals. Also outpatient appointments, expanding them within DASA and NGOs. Outpatient withdrawal programs, looking at expanding that. GP inReach, I'll go into all these in more detail too, and the mental health inReach. So all the projects, because we were fortunate enough to actually respond quite well, they've all been extended and are continuing on for a further 12 months in response to COVID, all except for the consultation liaison service, which, like I said, I'll go into more detail in what that means. The Addis phone line, outpatient appointment and mental health inReach projects will also be continuing on an ongoing basis. So we're in a really fortunate position to sort of respond better to those needs in the community for the increased demand, but also work sort of in a more integrated way with mental health services as well, which is really important. So the Addis phone line, just going into the projects and sort of in a little bit more detail to give you some more insight, and I just realised the time, so I'll nip through this relatively quickly because I know you guys can read back on this later. So what we were able to do was we were able to expand the Addis phone line by, now forgive me, I actually didn't write down the FTEs, but I think it's about 3 FTEs with the Addis phone line, which has been really, really important. So that's been a really outstanding response, whereby now the waiting list has actually reduced to anyone calling the phone line, and we're able to respond better. And what they do as well as part of these projects is that now we have a dedicated rapid response phone line. So rapid response is an approach we've taken with these projects, with keyly with outpatient services, but Addis obviously support that as well. So rapid response is whereby if someone presents to hospital for an alcohol or other drug issue, usually there might be a long waiting list if they want to be referred on for an appointment or for further support to see for outpatients. They might be waiting, anywhere. It might be a quick appointment, but they might be waiting some time. Rapid response means that if someone's referred on through their emergency department admission, is that they'll actually be offered an appointment within 48 hours. So that's what we were aiming at. So in order to increase that likelihood, we provide that dedicated phone line. So any clinicians calling from the hospital are able to call that phone line and get people booked in straight away to an outpatient appointment, either at DASA, or if they weren't suitable for DASA, we were able to link them in with NGO services. So that's been really successful and has responded to increased service demand, and also increased the likelihood of referring to NGO services that are more appropriate for clients as well. So that will be continuing on an ongoing basis. The client liaison service was, like I said, the specialist AOD nurses within hospitals. That expansion, normally they operate between Monday and Friday at a lot of the key hospitals. The three key ones being Flinders, Royal Adelaide and Lowell Mac. Lowell Mac, the CLS service expanded to include weekends until the 30th of June. This, however, hasn't been extended, and that's just because we haven't had a significant increase in demand. Like, we didn't get the numbers that we were hoping with that. However, saying that, the service will still continue from Monday to Friday ongoing, so that's still a continuing service. So, and they link in with other services as well, so that's quite an important referral service. Now, the outpatient appointments is sort of one of the big projects that we've been working on, and this has been continued ongoing as well. So that's about responding to that increased demand and taking on clients through that rapid response service. So any clients presenting to emergency departments or any acute service are able to get an appointment within 48 hours. And that may be directly linked in through our CL staff, might be from clinicians on the ground in emergency departments, could be from, medical officers can directly book people into those appointments. It's also about linking in through the ADIS phone line to NGO services if they're not DASA eligible as well, but they're eligible for other services. And like I said, that's about trying to aim for that quick turnaround or quick offer for an appointment for within 48 hours from discharge, ideally, if the client obviously is voluntary, is voluntarily accepting that. And basically that's about providing not only a better cost-effective service for us in delivering those services, but also about linking in people with support while they're going through a difficult time, and they might be experiencing acute issues related to their alcohol drug use. And like I said, we see quite a lot of those presentations, including mental health, either existing diagnosis or disorders, or it might just be a particularly difficult time where people are having a peak response and need that support, quite urgently. So it enables people to link in with services. And then ideally, if they do need further support, they're able to access it because they're already engaging with the service. And then hopefully we can keep those emergency department presentations down a bit lower. So what we've done is expanded that at all our three metro clinics. We had an extra 1,500 appointments provided. We also provided Saturday clinics and Monday evening clinics. The initiative will continue ongoing, but we will no longer be providing the Saturday clinics at this stage, and that's only based on low utilisation of those appointments. So even though we had, we'd heard anecdotal data from existing clients that they wanted after-hours appointments, and that's what the data was showing. When it actually came to utilising those appointments, it was very low. So at this stage, we're still doing Monday evenings, but the Saturdays will be reviewed depending on how we go and how we track with that. And there was a recent survey done with existing clients of DASA to see if they wanted those after-hours appointments, and the feedback was quite low for, even though there was some interest, it was more interest for one after-hours clinic. And Northern already provides an after-hours clinic on Thursdays as well, which is quite useful. So the rapid response model will continue. However, the outpatient appointments will no longer, for the expansion, will no longer be just focusing on rapid response model. It will also be allowing for existing clients or other clients from the community to meet that demand of people that want to have, to see a clinician or to seek further support. Anyone can access those expanded services if they're eligible for DASA services. And part of that outpatient expansion too was about expanding outpatient appointments through currently funded non-government organisations. So until the 30th of June, we had an additional 1,000 appointments being delivered through the NGO sector. That will be continuing on for the next 12 months, but we're still reviewing as to where they will be allocated at the stage, because that is ultimately informed by utilisation and utilisation trends previously, as well as those areas that have been identified as high needs and where the emergency department presentations are happening. So that's still being reviewed currently. What we've also expanded on is the outpatient withdrawal program. So that's currently through SANDA. So SANDA have expanded their in-home withdrawal program to support the clients, and that's about expanding to a further reach in the Adelaide region and supporting people to undergo withdrawal from alcohol and other drugs in their own environment at home, which is a really great, offer to provide people that don't have to be in a clinical environment. It's an alternative to the inpatient withdrawal. And also they provide, as part of that project, there's the withdrawal support, but then there's also an ongoing support after that. So there's what they call aftercare, which is really, really important to sort of reduce the, but basically provide more ongoing and detailed support, and also to sort of support people with things like relapse prevention and, have, rather than people being in and out really quite quickly with normal traditional withdrawal processes, this is a bit longer than that. So, and also increases that inpatient withdrawal, increases that withdrawal capacity for clients, so as well as the inpatient offer that we have through withdrawal services. So that will be continuing for another 12 months as well. And we also have the GP InReach project, and sorry, I know there's a lot of information to get through in a short time, so I've tried to not go through everything in the slide, so you can refer back to it. And feel free to contact me if you have any further queries afterwards as well. The GP InReach project we've been doing for quite some time. So that was also funded through the earlier funding through COVID. So that was through stage 2 as well. That's about increasing support for GPs that are referring into DASA and sort of, reviewing, that includes reviewing the referral process and referral forms, making sure that GPs are aware of how to do that, how best to do that, how best to support their clients while they're doing that. As well as providing that shared care model. So if they do refer clients to us, instead of just, that being the end of their support for that client, they can actually continue on providing their regular GP support, knowing that they're seeing DASA, but also providing, the checking in with them on the GP's level, while we're also providing support here that's more specialist AOD support. Part of that project as well, which is relatively new, has been the implementation of the Suboxone shared care transition to discharge model. So that's about identifying that a lot of our clients that are on MATOD, which is the medically assisted treatment of opioid dependence, that a lot of them have been on the program for a long time. So for those people that are considered stable and may voluntarily be happy to move out of DASA, they actually have the option to be treated by their existing GP if they're on Suboxone, and rather than having to come to DASA clinics to be treated for their AOD MATOD support. So that's about our nurses supporting that transition out of DASA to their GP if they so choose to, and providing that shared care model and support still while they're transitioning. So that's still early stages, but that is an option for clients that are, stable and may not want to, be seen as DASA, be seen as being treated from DASA, may not want to be flagged as being treated by DASA anymore. So that initiative has been extended for a further 12 months. And saying that, even though it's been extended for a further 12 months through this funding, we actually have funds available because it's quite an important project to potentially, continue on with this project ongoing outside of that. Yeah, and it's sort of growing, so it's including things like the script check process as well currently, but yeah, it's a constantly expanding and growing project and model. So a big project we have as well that's really quite new, and even though we've done some sort of form of it before, is the mental health InReach. So that's where at the moment, until the 30th of June, we had 2 nurses working with this project. They were working as InReach into community mental health services. One is located down south at Salisbury Community Mental Health, one's north at Morphett Vale. And what they provide is similar to the CL service, whereby they provide capacity building for mental health clinicians to support and work with clients who have alcohol and other drug issues, but also they also provide a shared care approach, which is, providing co-assessments for alcohol and other drug use with individuals that have identified that they want further support with that staff, with a mental health clinician. They do that together, and therefore it provides, more of that integrated care, or more of that, that ongoing support, rather than people having to be siloed, rather than them having to see their mental health clinician for their mental health needs and see DASA separately. It's actually provided a service where they can have a lot of that actually provided together at the one service and one appointment, which is really great. So that's sort of moving more towards, that shared care model across the board of mental health and alcohol and the drug use, but without losing the sort of integrity and specialist services of alcohol and other drugs and mental health clinicians. It's actually combining their strengths, rather than, alcohol and other drugs becoming the poor cousin. It's more about making sure that those clients who have alcohol and other drug needs, they're actually being responded to and being supported as best we can. So that's going to continue on an ongoing basis, which also means that we are able to expand by another 2.1 FTE across local health networks. And that will also mean that we can provide more regional support as well with this program. So initially it may be through telehealth at this stage. We're not sure what it's going to look like, but at least it means we can provide more, traction and more support for those people in regional areas that require it, because as we know, services can be quite often thin on the ground. But that's been a really successful project. And we're really happy to see that working really, really well. So, like I said, there's a lot of information to go through in a very short period of time. So I've sort of, I know I've skimmed through it pretty quickly, but were there any questions at this stage?
Any questions for Michelle? We did have one from Joe from Port Lincoln, who wanted to know if the Suboxone shared care will be available in country.
I think, look, I'd say yes, it definitely will be. At this stage, it's early days. So whilst I'm not going to say we're not doing it, we're doing it as a more sort of targeted approach at this stage. But saying that, Joe, I think Port Lincoln is definitely on our list as being one of those areas of high demand. So it will definitely be an area that we will be working on. But what I'll do is I'll follow it up with you and see how that's tracking and see where we're at with that, because that is something that we definitely are doing. We're definitely expanding that to regional areas. So yeah, it's just about, the hard thing is, as we all know, is trying to find GPs who are happy to prescribe to Suboxone to clients. But this is actually quite a nice soft approach, I think, in the fact that it's about contacting GPs contacting clients' GPs, so they're already treating that client for all their other health needs, and contacting them about their Suboxone prescribing. So basically identifying that, a lot of the concern for a lot of GPs is we don't want to treat those clients. Those clients are difficult, but making them realise that they're actually already seeing that individual. They're already treating them for everything else. So it's about providing that more holistic service. So it is a nice soft approach to get more GPs on board, which is really important too for having more prescribers and, making room for more people who need to get on MATOD through DASA as well. So it's sort of a good, circle approach, I think, for the community, sort of really well needed, really needed at this stage.
Great. And Joe also asked about the availability of the COVID mental health responses in country, but I think you spoke a little bit to that about telehealth and that kind of thing.
Yeah, and also just about the NGO outpatient appointment expansion. Previously, because it was short-term projects, we didn't incorporate regional areas, but that is definitely something that we are looking to incorporate this time around with the funding. So I think there is potential for expanding into more country areas this time, which is exciting as well. Yeah.
Excellent. And Kieran from Mission Australia, with a bit more of a comment, agreed that there is a reluctance in country areas to work with Suboxone. So that program could be much needed. All right.
Yeah, that support's really important. So it'd be exciting to see where that travels actually. Yeah.
Excellent. Well, thank you so much for your time today, Michelle. No more questions. I can't see any coming up. So we might move along. Now, in our agenda next, I did have Sarah Killick from Pangoola Manamurna. Now, Sarah has only just logged on to the thing, and it's entirely not her fault. It's completely my fault. Michelle, I'll just get you to stop sharing your screen if I can. Excellent, thank you. Now, Sarah, are you happy to chat with the group? Have I thrown you in the deep end?
No, perfectly fine.
Okay, I apologise for that. It's entirely my fault.
Good. All good, all good, all good. So I'm Sarah Killick from Pangoola Manamurna down in Mount Gambier on Bowendick country. We have mental health. Firstly, we're a medical clinic, and then after that we have programs and services from that, such as mental health AOD. We have a Nunga playgroup that runs 3 times a week. We also have parenting programs, caseworkers for SUB, social emotional wellbeing, and then also outreach to Kingston, Bordertown, Millicent and Narracourt at least once a month. So that's a general kind of run of how Pangoola is. But in regards to our AOD, so we have 2, a male and a female AOD workers. Both of them already come with significant experience, especially working with Aboriginal and Torres Strait Islander communities. We've done a massive revamp of how we deliver our service in the last year, and really put it for self-determination for clients when we're working through our case plans with them. So initially the case plan is just the storytelling, and then from that, depending on the AOD workers' experience and skill set, we then set them and task them to develop areas that the client can really build resilience and focus. We rely heavily on external agencies as well, obviously for inpatient and also outpatient for rehab. One of those that has been a big significant one for us in the last couple of months has been New Roads down here. Big shout out to DASA as well. We do get involved and draw resources from them as well. Our AOD workers, our wait time is usually about 24 hours unless it's a weekend, and our referrals come in from, you can self-refer, or alternatively you can be referred internally or externally from another agency. So we're really pleased to get our wait times down to that. So that's an initial contact, and then usually an appointment in a face-to-face situation is done within 48 hours if possible, just depending on where the client is in our region. Obviously, if they're 200 k's away, then it might be scheduled for later on in the week, depending on where outreach is. So that's really probably it from us. We're small little operation, but we do what we can. Yeah, work heavily with the doctor, obviously. We have fly-in doctors that we also collate with from Adelaide, so they come in once a month each, and we rely on them heavily for different bits and pieces, and for a lot of our outpatient referrals and things like that. So that's me, that's us.
Thank you so much, Sarah, and thank you for jumping in at the last minute. I discovered with horror that I've been sending Sarah's communications to the entirely wrong email. So it's not her fault that she was late, and I really appreciate you jumping in to tell us about what's happening in Mount Gambier. So thank you so much, Sarah. Next, we are hopefully hearing from Scott Wilson. Scott, are you there? Do we have Scott?
Yes.
There he is. Great.
Sorry.
All
yeah,
right.
sorry, I haven't done a presentation. I had thought that Jimmy might have been coming to the forum, but unfortunately that's not the case. So you just have to hear me, and I don't have a PowerPoint, so it'll just be basically what we do. But for those that don't know, I'm the CEO of the Aboriginal Drug and Alcohol Council. We're a statewide service. We have, I'm actually sitting in my office at work today. It's quite interesting what you do sort of see in a lockdown. Like I saw a guy running past on Holbrooks Road just a minute ago with just a pair of shorts on. In the pouring rain, and it's only 7 degrees. Just had the SES here because a tree came down at the property next to us. But as Michael White said, we're essential services, and I didn't feel that I could sit at home whilst our staff in Ceduna and Port Augusta and that, unfortunately, because we got clients, need to be open. And we also run a needle syringe program here at Holbrooks Road as well. But anyway, in particular, before I get on to the country PHN funding, I'll just give you a bit of a background. Obviously, we do run programs here in Adelaide. In Port Augusta, we operate a residential rehabilitation services that is 12 beds for clients. We take clients from across the state as well as far away as Broken Hill and places like that. We run a day centre in Port Augusta as well, which opens at 7 or 7:30 in the morning. And between that and the Ceduna Day Centre, for example, we provide upwards of between 50 and 60,000 meals to homeless and transient clients who visit those centres on a ongoing basis. So even though we might be in a lockdown situation, for example, across the state, we still have 20 to 30 clients accessing the Port Augusta Day Centre for the last couple of days. Because these are people that either themselves are homeless, and it was pleasing to hear this morning that a lot of the rough sleepers in the sand dunes and that have now been housed in short-term accommodation in Port Augusta. In Ceduna, we also operate an after-hours mental health, alcohol and drug team. We operate we're probably the only youth AOD counsellor service in Ceduna, and we also operate an employment service where people stop drinking for a period of time. Then we employ them as casuals to go back out to country to either work with rangers or to cut sort of paths to cultural sites in the national parks and things like that, and that's been going really well. But in terms of Making Tracks, which is funded under the country PHN, and Making Tracks has been around for a long time. I think this year's the 22 years that we've had that successfully funded via initially via Commonwealth Health, and then the NGO treatment grant program, Country Health, and now with their new program as well. And so throughout that whole period, Making Tracks is basically adapted as a mobile treatment service. Which basically means that initially we were dealing predominantly with petrol sniffing issues in the APY lands and places like Yalada and Ceduna and things like that. It's interesting that in the last couple of years, I think Jimmy and that haven't done a petrol sniffing workshop or had to go to communities to sort of try and work with the local community to try and stamp out the petrol sniffing. Most of their work has been around methamphetamine and those sort of substances. But just last week, for example, I was starting to get phone calls from community in APY to sort of say that there's seems to be a resurgence of petrol sniffing. And there's a combination reason for that. Obviously people are bringing it in. Young folk, because petrol sniffing is an appetite suppressant. So if people are hungry and they're sniffing petrol, they tend not to be hungry. But yeah, so that's something that, and we've spoken to DASA and a few others about how to respond to that. but Making Tracks is to provide an effective drug and alcohol service in rural and remote South Australian communities through services based in Adelaide, Port Augusta and Ceduna. Try and provide a coordinated system of engagement and service provision. Provide support and assistance to the local substance misuse workers in the delivery of their treatment programs. Try and ensure that families and carers have access to information and or support. Provide information on harm minimisation, infectious disease, drug overdose prevention and relapse. Provide health and AOD workers, particularly Indigenous Australians, with support in the delivery of treatment, education and preventative measures within their community. Try and provide a bit of training and general backup for organisation and workers, providing substance misuse programs in their local communities. Provide culturally appropriate AOD prevention materials, harm minimisation, treatment models and options for clients. Effectively screen and access and facilitate access to the resi rehab where appropriate. And as has turned out, because of COVID issues last year, in terms of in March when the state went into lockdown, and then later in November and that, it has meant that to a certain extent, because a lot of those more remote communities such as Yalata and the APY lands went into what they call biosecurity lockdown, which means that people can't come or go. So that's sort of to a certain extent has hampered Making Tracks' ability to get to and provide services to those more remote communities. But in saying that, it's sort of opened up a whole new avenue for Making Tracks, because they now do all of the intakes into our resi rehab, for example. Jimmy and that will do the initial assessments and then basically give that to our counsellors, who will then follow up and then facilitate those clients coming into the resi rehab. And there was reasons for that. One of the reasons was for whatever reason, because we take Aboriginal and non-Aboriginal clients, the non-Aboriginal clients, it seemed to be a lot easier for them to access the rehab in terms of having all of the referral, having documents and all of that filled out, whereas when it came to the Aboriginal person, there seemed to be a bit of a blockage. So having Making Tracks now taking that, because they look at whether the client that they might be assessing is at risk, and if they feel that they're at risk by staying out in the community, then they'll actually facilitate their entry into the rehab as soon as possible. That sort of has sort of got a bit of a double-edged sword, as you can probably imagine, because we take clients whether they have mental health problems as well. And it has sort of meant on a number of occasions where we've taken through that process, we've got clients that have got severe mental health problems that don't really present perhaps initially, but once they're sort of in the rehab and things like that, then their mental health issues take up quite a bit of time. As long as we're aware of clients who do come with mental health, of what the issue is, that they've got sufficient medication, because a lot of them are on medication for at least a month. That gives us the ability, or Jimmy and that, the ability to sort of, you know, plug the client into service Pickawea or Port Augusta Hospital in ensuring that those clients with mental health do get their medication and things like that. So that's to a certain extent working quite well in the fact that the rehab tends to be full most of the time, if not all of the time. I did ring them today because one of the other programs that Making Tracks and that are involved in is called New Directions, which is a prison and offender program that we run in Port Augusta Prison, Port Lincoln Prison, community corrections in Ceduna, Port Lincoln, Port Augusta, Whyalla, Port Pirie and Coopedi. And what's happening at the moment is that prisoners are being released from Port Augusta Jail, which means that we need to, so they're being released into this lockdown situation. They might be coming from places like the APY lands, which are, you know, hundreds of kilometres away. There's no buses. So we're now sort of trying to work out with corrections how we can actually get those clients back home. We have a client being released from Mobilong Prison, for example, on Saturday, and we've organised to meet that client at McDonald's on Glen Osmond Road on the Monday, and Byron, the other part of Making Tracks, will transport that client to Snowtown, and then the rehab people will pick them up from there and take them to the rehab. One of the other things that Making Tracks does is that we do cultural camps into the Flinders Ranges, where we take people with drug and alcohol issues in there, mainly clients from the rehab, for example, where Jimmy will do AOD sessions in obviously a nice setting in the Flinders, where they might be out there doing cultural sort of pursuits such as hunting and then camping and cooking up kangaroo and stuff like that. The other part of what Jimmy was doing is, some of you might have heard about the Grog app. Well, we've actually been funded to develop a similar sort of tool, which is that we, for want of a better word, we're at this stage we're calling it the Drug app, and that will actually be a trialled in places like Ceduna and Port Lincoln and that, where we'll actually have a whole range of substances, in particular cannabis, methamphetamine, opioids, and painkillers and benzos, where clients will obviously be giving the Drug app, which has got headphones, and a series of questions about each of those sort of issues will be asked. It will also give us we'll be able to sort of, for example, come into a community and, without doing a survey on drug use, we'll be able to get a quick snapshot of what substances a given community will be using at a given time, and then be able to provide them with feedback on that. And Jimmy and Making Tracks will be heavily involved in the development and the design of those of that Drug app, and also in making sure that it's culturally appropriate. At the moment, due to the rehab manager actually went on holidays just before lockdown, Jimmy is the acting manager of the rehab. So Making Tracks is, to a certain extent, is integrated into a whole range of different services that we do provide. Clearly, they have to be on top of not just single-use substances. They have to be on top of all substances and be able to provide advice and respond to issues that community might have. So I suppose it's good from our point of view that we've had been able to continue with long-term funding, even though it's short-term. If you understand, we get annual funding for these programs, but we've actually been able to have Jimmy and Byron, who've been employed in that program or programs for well over 15 years now. So it's been a very long journey. If there's any questions you'd like to ask me about, in particular about making tracks, but if not, thanks for your time.
Thanks, Scott. Thanks very much. Do we have any questions for Scott? No? Jimmy's sounds like a jack of many trades, as so many people are in drug and alcohol, and particularly when you start working in the regions like ADAC is, you have to be very flexible and very nimble to be able to provide that service. So I think it's an interesting example of picking someone up from prison and then handing them on to make sure that they get that continuum of care and get into that rehab where they need to be. So well done to all your staff around that. Doesn't seem to be any questions popping up, so I think we can safely move on. People might be a little bit nervous about what's happening with SA Health. I've just been keeping one eye on the news. So, SA Health's just had a press conference. Apparently there's been 2 more cases associated with the winery. They seem relatively pleased that it hasn't exploded, but obviously still keeping across everything and just encouraging people to keep an eye on the exposure sites and to get tested if instructed. What I think we might do is just maybe take a 5-minute break at the moment, just to let everyone stand up, have a stretch, check that list of exposure sites if you're concerned, make sure you're across that, and we will commence again at 11:55 when we'll hear from Thorn Harbour Health. Thank you. Okay, we will keep cracking on. Hopefully that's been long enough to quickly grab a drink and check the news if you need to. Our next speaker, I'm hoping Venetia is there from Thorn Harbour Health.
Yep, I'm here.
Excellent. Thank you, Venetia. I will hand over to you.
Great, thank you. Let me just share my screen. Ah, I had it all sorted and now it's disappeared. There we go. Okay, hopefully that's working. And hopefully you can all hear me. If you can't, please say so. So I'm Venetia Brissenden. I'm from Thorn Harbour Health and I'm coming to you from Melbourne. I'm on Wurundjeri country today. We're going to be, we're very excited to be starting up an AOD service in Adelaide, and we're obviously kind of new players in this space. And so I'm just going to talk a little bit about what we're going to be doing. So we are an LGBTI community controlled not-for-profit governed by our members who are community members. And we provide a range of services for our sex, sexuality and gender diverse communities. So you may have heard of us. Originally, we were the Victorian AIDS Council, and we changed our name a few years ago, about 3 years ago actually, in recognition that we were moving more into LGBTI health more broadly, not just HIV, and also not just being a service for gay men, like moving into other areas of the acronym, and also that we work across more than just Victoria. So we have a few national kind of programs and also have been in SA for a little while, which I'll talk about in a tick. We provide a range of services to the broader LGBTI community. Obviously, health promotion is a big part of what we do, health promotion around HIV, STIs. But we also provide a number of therapeutic services and other health services. So we have a family violence program, we offer general counselling, we have a couple of GP clinics. So one is a general GP clinic and the other one is called Equinox and is particularly for trans and gender diverse folk. And we have rapid HIV testing and STI testing. We have HIV support services. So we have the Positive Living Centre, which is a drop-in support service for people living with HIV. We have some housing. We offer NDIS services as well. Yeah, so quite a range. We're probably around, we're 100 plus employees. I'm not sure exactly how many EFT, so a mixture of full-time and part-time staff. We have offered drug and alcohol services in a number of different forms since around 2010, but we were funded in 2014. The whole Victorian drug and alcohol service system was decommissioned by the Victorian government. And we have a bit of a different system in Victoria. The government doesn't actually provide any direct services. It's all NFPs and NGOs, and they were all decommissioned in about 2014 and rationalised. And we were funded by the Victorian government for the first time to provide statewide LGBTI specialist AOD services. I guess that's the experience that we would be bringing to South Australia. So we already have a presence in South Australia. So with Shine SA, we deliver SAMESH, which is the South Australian Mobilisation and Empowerment for Sexual Health service in Hyde Street. And it's really provides community it provides education, training and advocacy around sexual health and HIV, but importantly from that kind of community perspective. So it's staffed and the services delivered for the most part by community members. And there's a very large pool of volunteers as well from community, which is great. What we will deliver in what we're planning to deliver very shortly in South Australia is intake and assessment, obviously, but also brief interventions. So we did a bit of a look at service utilisation in our Victorian drug and alcohol AOD service, and found that a lot of people were attending, 1 to 3 sessions. Like there were a lot of people who were just attending that part, and that seemed like that was kind of enough. And so we've sort of built that into this model. So we're providing a brief intervention, and I think that's really useful for people who might just want to check in about their substance use. Is it a problem? Is it not a problem? Get a bit of feedback about how they're going, some harm reduction information, maybe a little bit of motivational interviewing to encourage them to explore more. But also people who've engaged in some kind of treatment can come in for a bit of a tune-up or a little bit of relapse prevention if they're feeling a bit wobbly, etc. So there'll be a brief intervention. And then counselling of up to 12 sessions, with the aim there being, if people want to cease, reduce use or reduce the harms associated with their use. And then care and recovery coordination or casework. And that's for people with higher needs or complexity. And really it's about helping people coordinate the different treatment types that they might need to engage in to kind of successfully, make and maintain behaviour change. We also, in Victoria, we run a number of peer support and recovery groups, including one called Rewired, which is specifically for men who use methamphetamines in the context of sex with other men, so also known as chemsex and party and play. But we also have a group called Admin, which is for trans and gender diverse people with substance use issues, and Drink Limits, which is for LBQ women who have a problem with alcohol. So we would explore also the possibility of delivering those sorts of groups, because they're quite well received in Victoria. So it'd be good to see if that was the case in South Australia as well. So this is just a bit of a sorry, it's very hard to read because the text is quite small, but this is kind of our client journey. So obviously people can engage, while people are engaging in casework, they can access all the other service options as well. They're not sort of mutually exclusive. We also plan to do some, I guess, sector capacity building workshops, just some training on the relationship between substance use and LGBTIQ. And we'll certainly advertise those when we're ready to deliver those. So I guess one of the questions that you might have is, why is an LGBTIQ specific service needed? And there's lots of research that says that shows that there's higher levels of harmful substance use in our communities, and that the actual substances used and the harms vary with sexual orientation and gender. So patterns are slightly different from bisexual people to gay men to lesbian women. We know that there's even higher levels of kind of mental distress, etc., and so on in the trans and gender diverse community. So it's slightly different depending which part of the rainbow, sorry about that you're talking about. And the drivers of substance use are closely related to the social and relational contexts in which that use occurs. So, for example, and you can see that in the groups that we run. So an alcohol-focused group for lesbian and bisexual women, and a methamphetamine focused group for gay men, because there are sort of social contexts in which those drugs are used specific to those groups. Other drivers, of course, are the socio-political environment in which we all live, and you know, gender and sexuality related stigma and discrimination, and the kind of minority stress that LGBTI people experience. So an LGBTIQ plus service is more attuned, I guess, to possible changing trends and the cultural differences for our community members and in terms of substance use. We also know that service use is lower in our communities, even though substance use is higher. And it may be that people may not know that there's support available, but also a lot of it's not uncommon for LGBTIQ people to have negative experiences in healthcare settings that makes them reluctant to go back and access services. So being misgendered, that, you know, having to come out again and again, or being, you know, having their, or being invisible, like never being asked. There's a variety of different sort of experiences that people can have that means that they feel uncomfortable and don't want to necessarily access that service again. And this is particularly true for trans and gender diverse people. And this was I don't know if people are familiar, but there was a really big study called Private Lives 3 that came out recently. And almost a quarter of all the respondents in that study stated they would prefer a service that caters only to LGBTIQ plus people. And for non-binary people, that figure went up to 39%. So it's quite high. And I worked for a really long time in mainstream drug and alcohol services, and then moved to Thorn Harbour Health in LGBTIQ specific AOD work. And honestly, I've never talked so much about sex, you know. So, and it's not that I hadn't done assessments or done work with, you know, gay men, for example, in the AOD service that I worked in before, but the conversations were different because people felt that they had an expectation that Thorn Harbour Health would be a safe, culturally affirming, sex positive space where they could actually talk about their relationships and their substance use and the ways in which they were using without judgment and be understood. And so I was really quite amazed at how different the assessments were and the different information that I got from people. So clients come to us for that reason, because in our communities, drug use is closely associated with sex, intimacy and sexual identity. But also drug use is used to manage shame, stigma, discrimination, internalized homophobia, biphobia, transphobia. And because of that perception, whether it's real or not, of other services being unwilling or unable to explore that intersection. They have an expectation that they're going to find staff who work from a sex positive, HIV knowledgeable and LGBTIQ plus culturally safe and affirming framework, which I think makes a big difference. That's it, I think. So we've interviewed, we're not quite up and running yet. We will be very shortly. Borders reopening and COVID and pandemic lockdowns allowing. We can support clients in the meantime with telehealth, which we're doing with our clients in Victoria. So we do have an intake number that people can contact, which is up there on the screen. And a specific South Australian AOD email address and website will be coming soon. We will be located at the Cottage in Bow Street in Woodville, but also outreaching, you know, as needed. If your service would like more information, I'm really happy. I'd love to be talking to people about referral pathways, getting those set up. But also we're really happy to be, you know, we're only a small service. We've got, you know, a coordinator, a counsellor and a care and recovery worker. and we're not going to be able to meet the need everywhere. So we would love to be also available for kind of secondary consult or information for any other AOD service out there. So please do feel free to give us a call or drop me an email if you would like more information. And we look forward very much to working with you all.
Excellent. Thank you very much, Venetia. Sorry. Does anyone have any questions? Oh, hang on. There's one here. Says, hi Venetia, firstly thank you. This is a sector of the AOD which has been unsupported for a long time. Just wanted to check the age criteria for your service.
Yeah, good question. So we're for adults, but I think adults is probably like 16 and up. Yeah, it's probably the age range.
Okay. Excellent. Thank you. Thanks, Tana, for your question. Yep, I can't see any other questions, but you'll certainly be able to contact Venetia going forward. And yeah, I'm quite excited about a program with that speciality in South Australia. And I think it's, I guess with my workforce development hat on, it also creates some great opportunities to work with the sector, with you and the sector more broadly, as well as providing some excellent support for clients. So
yeah, absolutely.
Welcome. Thank you, Venetia. Is Kieran about? Can we go on to Kieran if he's available?
Yes, ma'am. How you doing?
There we are. Thank you, Kieran. If you're ready to go, I'll hand over.
Oh, it's clunky, isn't it?
I think it's all the working from home and the ongoing learning.
Right, can folks see my screen?
Yes, we can, yeah.
Great, excellent. So, hello, I'm from Mission Australia. I know a lot of you in the sort of listing there, so this is what I do these days. Mission Australia is a faith-based organisation. It doesn't mean we're out to convert people to Christianity. In fact, when I interviewed at Mission Australia all those years ago, I was a bit nervous about them finding out I was a Buddhist. Turns out that's not an issue, which is nice. So the two programs that I'm here to talk about today, very briefly, you'll be pleased to know I have 4 slides and about 3 minutes talking. So the two programs I want to talk about are the Drug and Alcohol Youth Outreach Service, which is an extension of what we've always done at Mission Australia. This is actually our 30th year at Hindmarsh, which is fabulous. We have a lot of experience under that roof, and are really excited to be offering what looks like a very interesting program. So the age range for eligibility is 10 to 25, which is, I know, an eyebrow raiser for most people that I've presented these slides to so far. We're still working on how we incorporate all of the theoretical goals that we have for our clients when we get them in the front door. But I know the phrase step up and step down has got a bit of a seeing to today. That's not really how we operate. We tend to imagine our service provision to be more about getting young people in the door and working with them one-on-one, and then graduating them through a DBT group sort of program. We then envision people, if they need assistance in the future and they've been through our program once, to actually be able to come back in through our group program, if that makes sense to you all. On this second screen, I've tried something a little risky here. If anyone's so inclined, if you could try hovering your phone over that QR code and seeing if that works, that would be fabulous. So as earlier mentioned, I think the PHN talked briefly about the new service. We'll be based in Adelaide, Elizabeth, Hindmarsh, Noarlunga. That's right, Adelaide. Yeah, Hindmarsh and Noarlunga. We're open to referrals from anyone, whether it's individuals, family members, health agencies, child protection, corrections, you name it. I think that's about it that I want to hammer with the sort of changes in service. We've been around for a little while. We haven't really changed a whole lot in terms of what it is we're doing, apart from a new focus on groups. Hindmarsh actually hosts a number of teams at the moment. And one of the things we wanted to really focus on for the next 2 years was having a sort of peer-led approach to how we do our business. So that means getting our clients in and talking with them about how we best provide services that suit their needs. I'm very excited to see what the Thorn Group actually is. So I'll be pestering you at some stage, Vinny, about how we might be able to work together on some things. So the other team that I wanted to talk about is a collaboration between Sonda and ourselves. So we will have a range of professionals based in a number of Sonda sites across the state. The idea is that we work with people from non-English speaking backgrounds, First Nation workers, and we're recruiting as we speak for peer employees for that service. In fact, I've got a shortlisting panel in about an hour to go through those applications. So a big focus with this team is on the coexisting illnesses. I know this is confusing syntax for some of you, but last year when Mission Australia went through the comorbidity guidelines training, one of the first decisions we made as a group was to consult with our clients about the use of the phrase comorbid, and most of our clients really reject that phrase. They feel much more comfortable with the terms coexisting or co-occurring illnesses. It just seems less judgy and clinical to them. So we tend to use those phrases interchangeably rather than comorbidity. You'll see with this particular service, we're based in Sonda offices, both in the northwest, the central, the southern, and the outer southern. I don't know how much folks know about the sort of vagaries of Adelaide suburbs, but outer southern and southern are pretty much 5-10 minutes drive from each other, and west and north are a long way apart. So it is an interesting geographic reference, but nonetheless, you can see that we're sort of spread right throughout the metropolitan area. Our intention at this stage is really working with in-house clinicians about getting results for people who've been battling substance use issues, and there is no sort of age limit for us in terms of referrals or working with them. The other thing I just wanted to point out is I'm also working with 2 country teams across the state. They're in Berry and Whyalla, so both of those teams are newly established by Mission Australia, and I'm the clinical lead for the Berry office, and as you can understand, that being about, I think, 10 minutes drive away from the Mildura outbreak has been uniquely challenging over the last couple of days. These are 2 new teams, and we've recruited exceptionally well in those areas. I will just take a quick moment to thank Chloe from the country PHN. Their online training stuff has been exceptional for bringing new staff into the country AOD sector. And for those of you who haven't seen it, there's a thing called QPR training, which is a sort of suicide prevention management training that the country PHN run. I highly recommend that for folks who are interested in that particular part of their practice. I reckon that's just about it, really, from me. Quick and easy.
Excellent. Thank you, Kieran. Did anyone have any questions for Kieran? Apparently your QR code wasn't working, but I think the way you shared your screen had it partly covered, but if you get your presentation out to people and share it, and it might work that way.
Right. Thanks.
Excellent. All right. Thank you very much, Kieran. Next, we have Trish from Nuncoran Unity, if she's about.
I am. Can you see me?
Yes, we can, and we can hear you.
Can you hear me?
Yep.
Fantastic. Okay, what I'll do now is share the screen and pull up our... Okay, share. Okay, looks like it's not here. I had to tune out and tune in. Are we able to bring in the presentation that I sent you? Can you see that?
No, we can't see that.
Are you able to see? I got cut out a while ago. I came back in, but it looks like the presentation's not come with me. Are you able to pull up the one that I sent to you?
I will attempt to do that. Let me see.
I'll have a go at my end as well. Window. Come. Okay, can you see that?
Hang on just one sec. I will stop. Yes, we can.
Okay, so it's a photo of us, is it?
Actually, no, you're sharing the wrong screen.
Okay, it's not here. Have you found it, Sam? I'll just run without it. How's that?
I'll have a go and see what I can do. Can people see that picture of the lovely Ngurrung Yunti team?
Yep.
Great. Excellent.
Okay, fantastic. I'll just run with that. Thanks, Karen. I can hear you. Okay. So this is us. We're the harm minimisation team at Ngurrung Yunti. All the people you see here are based in Adelaide, and we're the Aboriginal Community Controlled Health Organisation here in metropolitan Adelaide. We work with Aboriginal and Torres Strait Islander people and their families. We run an assertive outreach program into the Adelaide City parklands every day, and this includes a needle program service. We also are running this at this time during lockdown when our clinic is open. So at the moment it's on, we are going out tomorrow, Friday, and we will be there Monday as well. And we'll follow this up as we get updates from SA Health. We have a clean needle program which we run at our Wakefield Street site. Again, that will be open over lockdown in line with SA Health directions. At the moment, it's tomorrow between 10 and 12 and 2 and 4, and on Monday morning. We work with information and education. So I think Alan talked earlier about a relapse prevention resource we developed, and we were involved with some HEPC resources prior to that. But when we run our outreach track, we also have all the brochures and information that the sector develops, and it's an opportunity to pass those out to people that we meet. A lot of our work is brief interventions. They are on outreach. They also are people who come to our office at Ngurrung Yunti in the city, also at the various locations that we work at. So that's 180 Wakefield Street in Adelaide. That's our Brady Street Clinic in Elizabeth Downs. We also work out of Christie's Beach in Beach Road. We have inreach into the Flinders Wellbeing Centre at 28 Ann Street in Salisbury, and we've just started, or about to start, inreach into Port Adelaide at Tirupandi Wadley. We, as you can see with our guys in the picture, we have case managers. We have 4 case managers. We have 1 counsellor, and we're currently recruiting for a peer support. That job closes on Friday. So if you know anybody or have interest, please encourage applications, because if it doesn't work in this round, we'll consider them for other roles within NUNC. And our next smart relapse prevention group starts at, it's being run out of Ann Street in Salisbury, and that starts on the 4th, well, it's scheduled to start on the 4th of August. Okay, so how to refer to all of these services? We get a lot of people that self-refer, so we've been around for a long time. So a lot of these people are people that turn up, so people can self-refer either on outreach or walk in or give us a call. Our phone number, I forget, it's listed there, but it's 8406 1600. A lot of our, most of our referrals actually are internal referrals from the Nunka Wurrunyunti health services. We're getting a lot from our child health programs, which are based in Mile End and at Wakefield Street. We also have a mental health team. We have an NDIS team, and the GPs are running clinics every day, and there's a lot of working together in those spaces. Okay, so for external referrals, which we encourage more of, you can either email me, my address is down there, trishh@nunku.org.au. You can ring us on 8406 1600. We'll send a referral form to you, and if you can complete that and get back to us, that'd be great. All right, and with that, are there any questions?
Any questions?
No questions? Thank you.
No, I don't know. Someone, oh, Robert Bigney said, can you explain who the people are in the picture?
Can I explain who the people are in the picture? Of course I can. Okay, so that's Robert on the right-hand side. Okay, I can't actually see the picture at the moment.
No, I unshared.
Okay, but I know that picture. So it's Robert on the right-hand side. Left next door to Robert is Kay. Kay was our student with us. So she's been in and out of our team for about 3 years. And she now has just gone over to the housing program at Baptist Care. Luke is, that's me in the middle, and Luke is standing to our left. Luke does a lot of work down south at Christie's Beach and here in the city. Frida is our counsellor. She's come on board with a lot of experience in the AOD sector here in Adelaide. And George, I think most people would recognise George. He's been around for a long time, and he is our senior worker within our team, and he's great. All right, I'll say one more good thing about you, Robert. He's our key contact around Port Adelaide and the work out of the Flinders Wellbeing Centre in Salisbury. And thanks for your question.
Excellent. Thank you very much, Trish. Does anyone have any other questions for Trish? No, I'll have to work out how I'll get my screen back. Gosh, it's technology. It'll be the death of us. Okay, we're nearly to the end. We've just got 2 more short presentations left, and then we'll be done. So I know we're running slightly over time, but we'll get through there, I think. So Mel, if you're around from StreetLink. Hopefully Mel's there.
Yeah, hi everybody.
Great, hi Mel.
So thanks very much for having me today. I'm actually representing StreetLink. So Beck Kennedy is actually the service manager of StreetLink at Uniting Communities, but she's not working today, so she kindly asked me to jump in and present to you on some of the I guess funding changes to StreetLink. So I mean, we were very fortunate in this round to be refunded with a few extra additions. So I'll just go through the notes that Beck has provided me. I don't have any sort of fancy PowerPoints or anything that are going to fail me, so I feel quite confident just reading from the screen. So we'll kick on from there. So most of you would probably know StreetLink Youth Health Service. It's been around now for the past 30 years. So StreetLink Youth Health Service provides primary care to young people aged 10 to 24. It's existed in South Australia for over 30 years, and we are proud to see it continue to connect with some of Adelaide's most vulnerable young people. The service offers AOD counselling and case management, as well as medical support for young people. We have a GP and a nurse on board, which is just fantastic. It also partners with DASA to deliver the Clean Needle program. We're still delivering that at the moment, and we're still delivering walk-in services as well through our U City office on Franklin Street through this lockdown period. StreetLink applied for ongoing funding through the Adelaide Primary Health Network, and we were successful in our application. Through the application process, StreetLink was successfully funded to provide AOD services for the most complex young people aged 10 to 24 who wish to address AOD concerns. Apologies for all of those phone calls. As you can all imagine, living in this COVID lockdown state, there's a lot going on. We also provide support to people's loved ones and family and friends that are also seeking support or wish to play a part in a young person's recovery journey. The following services are offered through the StreetLink service. So book sessions at StreetLink's hub at U City in Franklin Street, Adelaide or Uniting Communities, Smithfield and Christie's Beach offices. At a mutually agreed location in the community, we can meet up with young people, so including but not limited to home visits where a risk assessment has been conducted, in Kalana Tapa, Adelaide Youth Training Centre, in shopping centres, parks and other community services. We do drop-in support at our U City site where young people can essentially just present during business hours, and staff will connect with them as soon as practical to commence assessment and support what needs they might have. We deem ourselves to be radically client-centred, and we try and always make sure that we're super gentle and client-led. StreetLink also formally operates from a number of youth-friendly services and locations at set times during the week, breaking down the barrier to meeting and connecting with vulnerable young people who may not otherwise consider connecting with an AOD service. This means we work from a number of schools, usually those with flexible learning programs, different youth services around Adelaide, as well as headspace centres. By being in these spaces and places the young people are already connected to, the service has the opportunity to develop rapport and trust with young people, which can allow them to begin and discuss substance use in a safe and non-threatening manner. As most of you would know, many young people often don't present or identify as having a substance use issue. So being able to connect with people, the young people through these other avenues is really important. With our community nurse, this role offers a soft entry for young people into the service, as it can feel much easier to come in because you don't feel well or that you're seeking treatment for something than to ask for assistance with substance use. Our community nurse can provide a holistic health support to clients, including sexual health checks, general medical assessments and referral to specialist service where needed. StreetLink also has a separately funded GP, and so young people who access our community nurse often connect with our GP also. The community nurse works very closely with the rest of the AOD team to provide wraparound care to the clients. So the community nurse, we've also extended her presence out in the north as well, as that's been an identified area where young people need that assistance. Through this new funding, StreetLink are excited to announce that we will have 2 new positions of support available for clients. So we're moving forward with an AOD peer worker and also an ATSI AOD peer worker. While the service has successfully filled the AOD peer worker role, we are still seeking out an ATSI AOD peer to join our service and organisation. So if anybody knows of anybody that's looking for an exciting new opportunity, please feel free to make contact with either myself or Beck Kennedy. And we'll be working in close collaboration with Uniting Communities Aboriginal Community Connect service. If anyone knows someone, I've just said that. So additionally, the service will be offering some extended hours 2 days a week through to 7 p.m. So we're not set days at this stage, but we will communicate with the sector shortly as soon as we come up with what days they will be. So that's pretty much it from a StreetLink perspective. So pretty much the same sort of thing as we've been doing for the past several years with those really new exciting additions of the peer workers. So we're really looking forward to operating in that space and expanding that medical service across metropolitan Adelaide. So thanks.
Excellent. Thanks, Mel. Does anyone have any questions for Mel about StreetLink? No? StreetLink have been around for a very long time, just in fancier digs now. and getting out into the community, which is awesome. Lucky last, Debbie from SANDAS, if she's about.
I am, yes.
Hi.
Let me just share my screen. Okay, you'll be pleased to know that mine is very quick. I've only got a few slides as well. Just a second. Okay, so yes, my name is Debbie and I'm the AOD Services Team Leader at SANDAS. I'm actually here on behalf of Andrea Gregory, who looks after our country mental health and AOD team. And the program that we wish to introduce for today is Andrea's program called Evolve, which will be funded across the Barossa Hills and Fleurieu area. So before I do get started, I would like to also acknowledge the land that you may be meeting on today. I'm currently on the lands of the Paramount people in the Adelaide Hills and pay my respects to elders past, present and emerging. I also like to just pay an acknowledgement to lived experience as well, where SANDAS is very big currently on recognising, acknowledging the benefit and learnings that come from the lived experience, and that we recognise the vital contributions and value the courage that has been shared in sharing their experiences as learnings to achieve better outcomes for all. So in a nutshell, in this one slide is just the introduction of what Evolve is. So very briefly, funded by the country SAPHN, it will be a comorbidity service for adults wanting to address their concerns primarily around alcohol and other drug use, with mental health issues coming on as well as a contributing factor to their substance use as well. It is an integrated care model where there will be a team of comorbidity clinicians as well as AOD peer experience workers who together will provide our client with that wraparound service of intake and assessment, brief intervention, primarily delivered by our peer workers, as well as then the treatment component of counselling and what would traditionally be focused psychological interventions that are usually delivered by our mental health clinicians, that will be delivered by our comorbidity clinicians. So we're definitely looking for an experienced AOD worker that has the ability to provide both types of interventions to our clients. It will be individualised support as a result of that. So where the intake as well as the aftercare, as I mentioned before, is going to be primarily be supported by peer workers. We like to bookend a lot of our services with our peers by starting and ending with them, with the peers kind of interjecting and collaborating in between all stages of treatment as well. So as a result, the goal setting and collaborative care treatment planning will be done in a collaborative way, where it will be with the client driving it with both their comorbidity clinician as well as their peer worker involved in that treatment planning, so everyone knows who's doing what. In a nutshell, around the eligibility, very simple. It's 16 years and over, with people presenting with AOD as well as mental health concerns, whatever that may mean. It doesn't have to be a diagnosis, just that there is both presenting. Referrals are very easy in terms of it can either be done over the phone or by a referral form on our website that you can go through. GPs are also able to make direct referrals in via the use of a mental health treatment plan, but it's not required. In terms of service location, so whilst we were given the Barossa Hills and Fleurieu area, we're going to be establishing primarily in the Gawler, Barossa and Lower Fleurieu, with a monthly in-reach and telehealth options as well to the Kangaroo Island regions as well. So it is primarily going to be, the hub will be primarily in our Nuriupla office, with offices also in Evanston. So that covers that Gawler-Barossa region with those 2 offices. The Fleurieu will be covered by our office in Victor Harbor, as well as then also a, I believe, a monthly in-reach to Kangaroo Island as well, which will be in Kingscote at their community centre, is where I believe that a co-location will be. In terms of if you want to make contact, please do contact Andrea Gregory, who knows far more about this. Her contact details are there at the bottom with her mobile and email address. In terms of making contacts for clients, primarily, as I said, the base will be from our Nuri office. So that is our Nuri number at the top there. But there is also just our general SONDA number as well for general inquiries as well. At the moment, we are still recruiting. So we're still, we have interviews happening next week. So we have Karen, who is one of our senior workers at the moment, who is servicing across all the regions at the moment. She started at Victor Harbor this week and then was told that we're going into lockdown. So she made the quick drive back home. So we'll pick that up again once we are all able to do so. Any questions around that, please feel free to ask. Alternatively, I've also just a quick update. So I look after our metro-based regions. So we're very excited, as Kira mentioned, to be part of the Partners Toward Wellbeing partnership, as well as Michelle also mentioned before, we're happy to announce that, yes, DASA has extended our in-home withdrawal program as well for another 12 months. So then that's both our DOE and DASA funding for the in-home withdrawal program will be continuing for another 12 months, which will also result in potentially some expanded regions. So watch this space. Once that's all confirmed, I'll let Sam know and she can distribute that information through to any changes we have around that, which we're hoping will not just be geography, but also criteria for demographics and age ranges that we're hoping will be able to, cover a larger pool of people. So any questions around any of this, please feel free to ask.
Excellent. Thank you very much, Debbie. Can't see any questions coming up on the chat, but if you've got any, throw them in. Just a few things to finish off with. Thank you for hanging around. I know we've gone a little bit over time, but I appreciate everybody hanging around. No, I don't see any questions there, Debbie. Just a couple of things to mention. The email with the evaluation link for today's event should already be in your inbox, I hope. So please just take a couple of minutes just to answer a few short questions. Your feedback is really helpful. The other thing is you might have seen a link for another survey circulating from SANDAS about networking. If you see that come up, I've included it in the email. It'd be great if you could take a couple of minutes just to think about your networking needs. We're really interested in hearing how people want to network, what kind of events and meetings and stuff you'd be interested in attending. So if you could take a couple of minutes to respond to that too, that would be great. It does look like we might be heading towards a networking event before the end of the year, which we're kind of extra keen for now because we didn't all get to be in the same room today. So we may be looking at something co-occurring with our AGM later in the year. So kind of, I guess, watch this space, but we're really interested in hearing about networking because networking is changing in these times as well. So just a really big thank you to everyone for attending. We're thinking of you all in lockdown, particularly those frontline workers, those essential workers who are still providing services either from offices or from home over the phone. Please take care of yourselves and let us know if we can do anything to support you. And I think that's about it from me. Michael, are you still there? Is there anything else you want to say?
Two things. The first is the SANDAS 2021 member survey is out on SurveyMonkey, and some of you will have been sent a link to that survey. Or if you haven't been sent a link, can you please poke your line manager or CEO to respond to that? It's really useful data. And it builds a really rich picture for us with other forms of or other sources of information. If you haven't got a copy of it and nobody in your organisation has, please send me an email. Finally, I'd like to say thanks to everybody just for being here and persisting, and it's been great that most of the technology except my video has worked. And I'd really like to thank Sam for pulling it all together at extraordinarily short notice. Please go back to the website, and if you want to review any of the presentations, they'll be up on the website under today's forum. And look after yourselves. Thank you.
Thanks, Michael. Maybe just give me a few days to get that all up on the website, but it will be there eventually if you want to review everything. But hopefully you've got some information in your inbox. Please give us some feedback, and thank you all for attending. Stay safe, everyone.
Thanks, Sam. I never agree with Michael, as you know, but you've done fantastically well today under the circumstances.
Thanks, Sam. Thanks, everyone. Thanks, Sarah, for your last minute. Thanks, everyone.